You are live, ma'am.
Just 1 minute. Yeah. A very good evening to one and all of you for a very unique webinar of its kind, which actually is going to let us all dwell into thinking of becoming ageless, maybe, of course, also about fighting the sequelae of the disease processes with no evidence of its rampage, and the challenges which you face to avoid disfiguring. And I'm sure there's a lot more to it. And let's all stay glued for the next 2.5 hours, because there is going to be just so much to learn in this terrific show which we have ahead of us. And we're truly lucky to have the best of expert panel and a great set of speakers. And we have with us Dr. Kasturi Bhattacharya, who's the Director of Clinical and Academics in Sri Shankar Dev Nethralaya, Guwahati. And she's actually into everything: cataract, refractive surgery, orbit, oculoplasty, you name it, and she's there. And she has a huge number of publications, both national and international, and a woman of great surgical prowess. And I'm sure she's going to add a lot of pearls to this webinar. We have with us Dr. Kamal Preet, who's again a senior consultant from Orbit and Oculoplasty Department from Ratan Jyoti Nethralaya Ophthalmic Institute and Research Center. And again, another very prolific surgeon, a very dynamic young lady, who's again going to lead us through this webinar. We are truly lucky to have with us Dr. Raman Mittal, another very proficient oculoplasty surgeon, medical director of iPlast Eye and Plastic Surgery Center, Amritsar. And we are surely going to be immensely gainful with all the pearls he's going to share. We have with us Dr. Milind Naik, a towering figure in the field of oculoplasty, both in the national and the international scene, is a consultant ophthalmologist, ophthalmic plastic surgery and facial aesthetics at L.V. Prasad Eye Institute, and also the adjunct professor of ophthalmology, University of Rochester, New York, a very capable, immensely capable person with his aura of self-confidence around him all the time. Co-moderating with me is Dr. Shubhra Goel, a hardcore ocular aesthetic surgeon, besides all her oculoplasty forays. I'm sure we all know that she's an immensely versatile person with a huge experience in this field of ocular plastics in ophthalmology, practicing in Apollo Health City, Hyderabad. Needless to say, she's going to steer this webinar with her amazing moderating skills. Rather, should I say that she's going to set the stage on fire with her opening talk on the avatar of an ocular aesthetic surgeon, my key takeaways. On to you, Dr. Shubhra.
Thank you so much, ma'am, and a warm welcome to one and all. I'm so blessed and so honored to be amongst the best of the best in ocular aesthetics. And rightfully said, ma'am, I think we're going to set the stage on fire, and we're going to take everybody, make more interested in ocular aesthetics. So when you gave me the talk on avatar of an ocular aesthetic surgeon, I was actually confused, because I was wondering whether I should take this talk, how should I mold this talk so that more and more people get attracted towards ocular aesthetics and this specialty actually becomes one of the mainstreams, which it is, but it needs a little more effort and a little more awareness. So welcome to all on the update series of ocular aesthetics. I think this is a great step by the AIOS series and All India series to bring forth the aesthetic practice, which has been increasing manifold. Thanks to all the pioneers and pillars of ocular aesthetics who are there as part of this meeting as well, Dr. Kasturi, Milind, Debraj, and my colleagues and friends from all over the country. Well, when you say aesthetics, I'm just going to take you briefly through my journey of how I turned from an ophthalmologist to an oculoplasty and then to oculofacial aesthetics. Because actually the beauty or the aesthetics is not something new. It belongs in each and every part of what we deal with in our life, whether it is your home, your pets, or even a beautiful cake, which I think I made for my better half. I hope he appreciated what I did for him. So beauty is everywhere, and it's only that we have to mix the science and art together and understand that we are just the right and left halves of the same individual, and we all have it within us. So when you look at my journey, I mean, obviously we all here present have been ophthalmologists. And while doing ophthalmology, at least I wasn't aware that there was a specialty called oculoplastics. But as a resident, I always wanted to do general plastic or plastic surgery. And then this key of plastic surgery was just sitting somewhere very, very, naive in my system. And I was searching, hunting for it. And thanks to, thank you to the, my seniors, my friends who diverted my attention towards institutes like Shankar Nethralaya and LV Prasad, where I knew that something called oculoplasty actually existed. And that's where I did my fellowships. And while doing the fellowship, I realized that my interest primarily lied in more of aesthetics rather than doing the core oculoplasty work. And of course, I have to thank my alma maters who have made me what I am today, apart from all my other seniors who have trained me every single day. I learn every single day from everyone. And this is just, a way of my thanking to my mentors, because if they weren't there, I wouldn't be sitting here and talking about my journey. Now, it hasn't been easy, and I'll come to that, why shifting from ophthalmology to oculoplastics and then to aesthetics hasn't been easy. But I consider it as one of my most fascinating and exciting journey, apart from the other, journey areas which are there. And it's still an ongoing process where you peel your layers every single day and understand what you need to do in your professional life. So the biggest hurdle or the understanding or the change for me was to come out of my comfort zone of institution to the corporate journey. And it wasn't easy initially, because institution was my comfort zone. I was the king or the queen there, and I was getting whatever I wanted to do. This journey taught me a lot, and it actually widened my exposure and the thought processes of how I want to take the ocular aesthetics forward. Stopping doing cataracts was another step, which was a big step taken, because when we started, cataracts was one of the things which we were doing, and everybody came and told me that please don't stop doing cataracts, that's bread and butter. And somewhere I had to decide of not doing it. Setting off an exclusive center in Shankar Nethralaya was a big learning experience. It gave me the confidence and the experience to move forward. The awareness for the specialty was not existent when I think Dr. Kasturi, me, Milind, and we all started, because it wasn't looked upon as one of the specialty in oculoplastics or in ophthalmology. So there was a lot of things which we needed to do in terms of spreading the awareness, talking about it. Of course, the allied specialties and our standing amongst them was very weak. And we wanted to prove to the world, and I think Dr. Kasturi and Milind would agree with us, that what is so different we are doing. A lot of people came and said, aesthetics has always been there. What is so different? Why do you want to label it differently? It's just part of oculoplastics. But I think beyond all these understandings and journey, there were new associations, expansive views and connections, new learnings. And for me, especially, I think what made me what I am today, and I'm still on this journey, as I said, is a stronger and focused part of me focusing on that part of the specialty. And that's how I started to, I started Clinica Phi, branding the work I want to do and do it in a way I want to do. And I want to project this specialty in the existing scenarios. The pillars for core aesthetic practice for me actually are surgical and allied. I think we forget a major part, which is allied. And I'm not going to talk much detail about all the procedures, but just take you through a journey of things which, have been my pillars in my practice. And I think the word which I would put here for all the budding ophthalmologists or people who are looking at ocular aesthetics is just look beyond. I mean, for most of the individuals, this face would be normal, but for us, this face is not. And we have so many things which can correct on the face. Now, there would always be a question about, aging gracefully, aging naturally, and we were just discussing about it. But yes, you can age gracefully and age naturally, but few touch-ups here and there makes you age even more gracefully and beautifully. So that's my take home for everything. Of course, the eyelid bags, blepharoplasty, periocular rejuvenation surgeries are a major part of it. I think Dr. Kasturi, Milind, everybody is going to cover it in detail. Hooding of eyelids. And I want to bring your focus on not only the surgical procedure, but the way the emotional quotient on the face of an individual actually changes with the simple surgeries like blepharoplasty and more. And this is one of the examples where the patient had come for blepharoplasty with brow lift. Patient didn't turn up for the post-op clinical picture, but this is what she sent to me. And she's just a housewife who has completely changed her personality after the surgery. Now, this is not me talking about, this is she talking and sending pictures to me. So the personality, the persona, the confidence, and the emotional question for people actually change, and it's pretty evident. And then there are different indications like orbital fat prolapse. And I didn't hesitate to operate on my own mother. And, she is a thyroid patient with hypertension on anticoagulants. And she came here post-COVID and she had nothing to do for 2 months. I said, you know what, mom, let's just make you a little more happening. This is she. Which I just touched her up a little bit. She was pretty upset with me. I still wanted to do the brow Botox, forehead Botox, where she has a surprise look. I wanted to do a little bit of filler on the lower face. I purposely cut her lower face because she has a distorted chin. But this is what gives you the pleasure of treating people around you, making them happy, making them different, bringing that difference in their lives. Skincare is one of the major part of our practices as surgeons, because if the skin is not good, the results won't be good. This is one of the patients who has been on the skincare, and these are real pictures where the skin has transformed over a period of 8 to 10 weeks, where the shine, the glow, the texture, everything has changed. Of course, you can do facial contouring where the square can be converted into V shape with simple things like Botox and fillers and injectables. And I'm sure we're going to have wonderful talks on that. Sometimes reconstructive surgeries do become part of your aesthetic practice, where this girl had prosthetic eye, her brow was not in position, lid was retracting, multiple surgeries being done elsewhere. And this is what we could achieve. And she has a squint in her right eye with a lid ptosis, which is pre-existing. Her vision is limited in the only seeing eye. So we just played around with some Botox and fillers, and this is how she is, after the procedure. Of course, these are my fancy tools where I use a lot of my skin regimes, and newer innovations, newer technologies are always a part of the game. You have to be in the game. You have to have allied, associations where you need to enhance the periocular area in a very, very beautiful way, because your periocular, perioral area is the first thing which gives the impression on the face. And this is me with eyelash extensions. It's not bad idea to do it once in a while and to change the whole persona around you. You can use lash serums, you can do extensions. So this is just a fun picture to show you that, how the personality actually changes with some of the basic aesthetic procedures. Of course, there are non-surgical procedures, and that's where your associations with your, partners or allied services comes in. If you yourself cannot have it in your clinic, or you don't want to do it, and definitely you need some Vaha moments, combination therapies, and soft procedures for our patients. So my quick takeaways from my journey and from what I have learned is that it's okay to stand out. It's okay to be different. People will think that you are different, but it's okay to continue. You are unique, and you need to have the passion intact of what you are doing, because that's what will keep you moving. No matter what experience you have, whether it is good or bad, it's always an experience. It's always useful somewhere in life. A lot of times we fail in what we do, but those experiences teach you a lot and make you a better surgeon, better physician, better person. As I mentioned, step outside your comfort zone. I think that's the biggest step and the most difficult step, which an individual, as a clinician, which if taken really helps. There is no wrong time to do the right thing. Whenever you feel what you want to do, just do it. And, don't get intimidated by your colleagues, your friends, your seniors. Do what you want to do. What is best for you? What are your strengths? What are your focuses? Never hesitate from learning new from anybody, whether it's your student, fellow, senior, junior, mentors. Choose your mentors correctly. And I think they are your, torch holders, and they take you to a next level. be part of training programs, learn from people who are teaching you. And as an individual, we all love teaching because teaching makes you a better physician and a clinician, and go beyond. It's not only here that you can give your services. You can give your services wherever it is available, wherever it is needed. You just need to be there as as an individual, giving whatever you have learned over a period of time, because it's just one life. And I think COVID has taught us that it's all, we just cannot be restricted to one zone, one area. Life is more to that, and our practice, and we are blessed to be oculofacial aesthetic surgeons because we can bring in so many changes on so many people's life. So keep moving forward, don't stop, and keep working on what you feel is the best for you. Thank you so much.
Thanks a lot, Dr. Shubhra. That was a really an energizing talk. Gave us a lot of insights on what you have done as you've evolved. But as an ophthalmologist, we're all trained to examine a patient in a particular way, right from the lids to the retina. But I'm sure in your specialty, you must be picking up subtle signs which even the patient doesn't know about themselves as what is wrong. So there must be a sequence of examination which you follow. So could you enlarge on that?
So that's a good question, ma'am. See, basically, as an ophthalmologist, the general ophthalmic checkup never stops. The patient enters the cabin with a basic ophthalmic checkup being done. But most of the clients or patients who walk in know what is happening to them, why they have come for us. They may not be knowing scientifically what is the disease process behind it, but most of them are aware of what is happening. And of course, the examination starts from, if I talk about myself, it starts from the upper face, mid face, lower face, which includes the skin, which includes the bony framework, and it includes the structures within that area. So if we start with the upper face, it includes your forehead and eyebrows, and comes your eyelids, orbit, socket, and everything down. So that's how I plan the examination, go step by step and see what is wrong, and then move forward onto the specifics. So if it is related to eyelids, for example, the patient has ptosis, and we go to jump to the ptosis examination. But the point here is it's always the ophthalmic checkup, then the full face checkup, and the specifics of the area which is affected.
Can I add something?
Yes, yes.
Okay. If you go to the textbooks or the basic textbooks of the American Academy, the AIOS series, it mentions that as an ophthalmologist, we are supposed to evaluate right from our forehead to the chin. So this is very pertinent, and it's very important that all ophthalmologists, we should not have a tunnel vision and only look to the eyes, but all ophthalmologists armamentarium starts from here to here. And that is what in the basic textbook of A also, you'll find the extensive, lectures, chapters on the blepharoplasty, neck leaf, the lasers, everything. So now, it has become a part and parcel of our ophthalmic resident training program also.
But Dr. Milind, do you have anything to add before I ask my second and last question for this talk?
Clinically, you could primarily divide patients into two broad groups. One kind of patient comes with a problem and they say that we want to fix this, like how Shubhra said, either ptosis or their under eye bags and so forth. The other is a patient who asks you an open question that I don't like my looks, I look tired or I look unhappy. So they use adjectives, and then you finally have to identify certain anatomic features which they can relate to that adjective that they have described. And once you match them, then you can fix the anatomy.
But with the kind of competition that you have, like the beauty clinics and the plastic surgeons and all dermatologists, so how do you show that you are different? Like, how do you differentiate yourselves in your practice?
You don't need to show you are different, ma'am. The moment the client walks in, they know we are different. So I think the way oculoplasty surgeon approaches to the specifics is totally different from what dermatologist or plastic surgeon would approach, with no offense to any specialist. This was just on a lighter note. And I think, as I mentioned, at the end of it, it is all combination services which matters. So I'm very clear that if I'm not able to correct something, this is the person whom they have to go to and get it corrected from. So I think at the end of it, it is a group practice. It's sharing of patients for specifics with the ethics in place. And I think over a period of time, people do understand that what you're doing is in the best interest of theirs.
Anybody on the expert panel have anything to ask Dr. Shubhra before we go on to our next talk?
Yes, ma'am. I'd like to ask a question, Shubhra.
Hello.
First of all, I'm sorry I joined in late, and thank you all. This is such a wonderful forum. Shubhra, I have one question. Like sometimes, like you say, patients come in with a set perception, what they want to look like or what they think is wrong with their face. But what if you feel, very commonly like in ptosis and lid retraction, one eye has retraction and the other has ptosis, and the patient is convinced that it is the ptotic eye which is wrong and not the retracting eye. So do you generally fall in with what the patient wants, because cosmetic is basically all about making the patient happy? Or do you do what you think is right in such cases?
So, Dr. Kamalpreet, a wonderful question. I think we all, have this issue. So I divide my patient into vanity and non-vanity patients. Patients who are belonging to the category of vanity is where they force you to do what they want to do, and they have unrealistic expectations. Most of the patients who are from the non-vanity group, when I say that, for example, your lid retraction versus ptosis, I mean, we know there is a structural issue lying over there and there is a reason behind it. And I think when we explain them scientifically, explain them the outcomes, they do understand. But yes, coming to the other category, it is difficult. I think a lot of counseling goes into it, but at the end of it, doing the minimum is the best, and giving them the realistic outcomes is the best. And if I feel that the patient or the client is not understanding that, it's like Ram, because I don't think I would be ever able to make them happy. I'm sorry for that grammar. Yeah.
Yes.
Yeah.
Thank you.
So we shall now go on to our second talk by Dr. Nidhi Mittal. It is Toxin to Medicine, Botulinum Toxin for Aesthetic Use. And she's a director and oculoplasty and aesthetic surgeon from Rana Eye Center, a super specialty eye center in Rohini, Delhi, a specialist in the field of plastic surgery of the eyelids and the surrounding tissue. On to you.
Thank you, ma'am. Thank you so much for this opportunity. Is my screen visible?
Yeah.
All right. So toxin to medicine. So as we know, botulinum toxin is a dreaded poison causing a serious illness called botulism, which has been known to mankind since time immemorial. So the most common form being the foodborne botulism. However, it was only in the late 19th century that the toxin was first isolated from the anaerobic bacteria. Clostridium botulinum was first isolated as a source of the toxin. So it was then that it was named after the Latin word botulus, which means sausage. Sausage, because it was very prevalent poisoning due to consumption of sausage in Europe. So in 1944, the toxin was first isolated in the laboratory by a biochemist, Edward Shantz, and this paved way for its therapeutic use, which was first demonstrated to treat strabismus by Dr. Alan B. Scott in 1980. So it was in 1989 that the botulinum toxin first got approved for therapeutic use in cases of squint, blepharospasm, and hemifacial spasm. However, it was fairly recently, in 2002, that first approval for cosmetic use came around by the FDA to treat the glabellar lines. So the toxin itself, it's a neurotoxin, as we all know, and it blocks the nerve signals to muscles, which causes temporary paralysis of the target muscle. So 7 serotypes are known: A, B, C, D, E, F, and G. Human botulism is caused by types A, B, E, and F. So commercially available types are type A and type B toxin, which is a highly refined purified protein consisting of the neurotoxin structure, the hemagglutinins, and the non-toxin non-hemagglutinins proteins. So the different formulations available to us commercially for type A are Botox, Dysport, Xeomin, type B, Neuroblock or Myoblock. So type A is available as a powder form, ready for reconstitution. However, type B is available in a ready to use solution form. Each of these formulations are made with some excipients in the vial. Human serum albumin is present in each of these formulations. Botox is available with sodium chloride. Dysport has lactose, and Xeomin has sucrose as excipients in the vial, which are available commercially. So the mechanism of action, the target tissue being the presynaptic cholinergic nerve terminals. So in the skeletal muscle system and the autonomic nervous system, normally in a healthy neuromuscular junction, the neurotransmitter is released at the synapse and the muscle contracts. However, the toxin, it binds and it is internalized in the presynaptic nerve terminal. It binds and cleaves with the SNAP25 protein, and it inhibits the release of the neurotransmitter containing vesicle in the neuromuscular junction, thus causing the muscle paralysis. So this action is used in its aesthetic indications and applications. So as we all know, wrinkles are the lines on the facial skin, which are caused by the repeated motion of the muscles of facial expression. So this toxin relaxes these selected muscles and allows the skin to recover, thus reducing the wrinkles. So this is the anti-aging effect that we are aiming for when we use this toxin. So around the eyes, botulinum toxin is used to treat the horizontal wrinkles on the forehead, the glabellar lines or the frown lines, the vertical lines between the two eyebrows, crow's feet at the lateral canthus of the eye, under-eye crepes in the lower lids, bunny lines by the side of the nose, and non-surgical eyebrow lift by depressing the action of the eyebrow depressors. So, however, it has been proven to be a very safe drug. There are certain conditions that we need to be cautious. So, if there is a history of hypersensitivity to any of the constituents of the injection, sensitivity to human blood products and foods, certain foods like eggs and milk. So, because it's a protein, so any history of hypersensitivity rules out the use of the drug. Very important, neuromuscular disorders of muscle weakness. So like myasthenia gravis, Lambert-Eaton's, and amyotrophic lateral sclerosis. So it's a contraindication for use of this neurotoxin. In conditions of pregnancy and lactation, however, there is no definitive evidence of risk of treatment, but no long-term safety studies are available. So it falls under category C. Local part infection and inflammation rules out the use till that part is taken care of. And flu and cold symptoms, if the patient is generally not well, so we can wait and schedule the treatment at a later date. So the preparation is quite simple. So normal saline is used for reconstituting the injection. And we have to be very cautious that the handling of the solution has to be very gentle. So vigorous shaking can denature the fragile molecule. And a very fine needle and syringe is used to draw out the solution from the vial and ready to be injected to the patient. So how much of solution is to be used for reconstituting? So there is a this easy reference dilution table can be used. So for instance, if we need a strength of 4 units per 0.1 ml of the injection, so in a 100 units vial, we will use around 2.5 ml of the normal saline. So depending on the strength and indication, so this dilution table can be used as a reference to decide the amount of the normal saline used to reconstitute the injection. So as mentioned, it's a very fragile molecule and easily denatured. So we have to be very cautious for storage and transport. So the cold chain maintenance is integral to the potency of the drug. No vigorous shaking of vial for mixing the solution, and sterility and disinfection has to be maintained at each step of the process in storage, transport, as well as injection. So an unopened vial should not be used beyond the expiry date as mentioned on the vials by the manufacturers. Usually it is reconstituted just before use. And a very important point, because different formulations are available in the market, each of them are not interchangeable. So 1 unit of Botox is the effect of 1 unit of Botox is not same as effect of 1 unit of Myoblock. So this has to be kept in mind. However, the manufacturer guidelines are that the reconstituted solution of botulinum toxin A has to be used within 24 hours of reconstitution. But with years of use, experience, and many studies to back this claim, if bacteriostatic saline is used for reconstitution and cold chain is well maintained during the storage, the reconstituted solution can be used up to 2 to 4 weeks with comparable potency as of a freshly made vial. So, however, it's a very safe drug with very predictable effects. Some adverse events do occur. So, unintended effects are the effects which occur due to spreading of the effect of toxin to the surrounding areas of the target muscles. But they are temporary and they are relieved with the loss of the action of the injected medicine. So very common being brow ptosis when treating the forehead wrinkles, and abnormal peaking of eyebrows, which we call as pop deformity, if the forehead is not treated in a balanced manner. Eyelid ptosis, while treating the crow feet, sometimes the injection spreads to the levator muscle, so causing eyelid ptosis. Ectropion and leg ophthalmos can occur while treating the lower lid. Diplopia and strabismus if the lateral rectus is affected due to migration of the injection while treating the crow's feet. Dry eye due to migration of the injection to lacrimal gland, thus causing decrease in tear formation. Epiphora due to lacrimal pump failure when we are injecting the lower lid medially or punctal ectropion. And while injecting in the lower lid, if the injection goes too low on the zygoma, it weakens the zygomaticus major muscle causing lip ptosis. So apart from these specific adverse effects, local part swelling, bruising, and pain can be a part of the process and they resolve quickly. Some patients can have also reported transient headache or flu-like symptoms, but they resolve. And a potential adverse effect is botulism, but it is very unlikely with the doses which are used for the aesthetic purpose. So thank you everyone for such a patient listening, and thank you for this opportunity.
Thanks a lot, Nidhi. Learned a lot. But the one question I have to the expert panel is, when you have these different brands, I know they are different complex proteins, but how do you decide what is your basis to select which one over the other?
Yes, so ma'am, so convenience, availability, also the effect, and all of them are comparables in safety and effect, but I think the most important being the availability of the drug where you are practicing. That is a very important factor.
Dr. Shubhra, on to you.
Nidhi, congratulations for a lovely talk on the basics of botulinum toxin.
Thank you.
I think coming to different brands, it depends. I think you have to have your own research and a comfort level of using which brand you want to do, right? As she mentioned that each brand has its own pros and cons, its own efficacy, longevity. So I think a good literature search on what works best in your hands is the key forwards. At the end of it, there are people who have tried different brands on the same faces for different indications and it works fine. But for me, for example, it is only one brand which I'm comfortable doing with, and I have got consistently, good results. So also the consistency and the repeatability of the results is very, very important in your hands. So that's what my take home message would be.
Thank you, ma'am. Definitely.
I would like to say something here.
Yes.
I agree with Dr. Shubhra definitely that the comfort level is important. The pricing also sometimes make a choice, and there are a few brands in the market which are less on price, and sometimes the newcomers or people who want to try with the lesser pricing can go with the other brands. I have tried few other brands, but as Dr. Shubhra says, Botox has a very consistent and very reproducible results and effects. So I am also very comfortable with Botox for the last, I think, more than 15 years now of the practice. And this is without any financial interest. And also about the dilution, which Dr. Mittal said, probably in our practice, we are more comfortable making a dilution of 100 units in 4 ml, which makes it about 2.5 units per 0.1 ml. There was a presentation which suggests that if it is more concentrated, then the dispersion area is lesser. So if you go with something which is about 4 units per 0.1 ml, the dispersion is around 1 centimeter. Whereas if you go with 2.5 units per 0.1 ml, the dispersion is around 1.5 centimeters. So you can have a better effect with a lesser number of units. So you can cover much more surface area. So as of now, I am very much comfortable making it in 4 millimeter in of 100 units. So that makes it 2.5 units per 0.1 ml.
Basically, I'll just add a point. Basically, if you look to it, am I audible? It is basically we have A, B, C, D, E, F, G, right? Or that it is only A, B, E, which has activity in humans. And all this onobotulinum toxin, that is the Botox, Dysport, Xeomin, Givau, these are all A. Okay. And now we have the B, that is the myoblock, neuroblock. So basically what we say that sometimes we need to switch over from A to B when we see that some antibody being produced. But nowadays we also have the biosimilars. I think there are people, I have no experience, but in India, I have seen that in many other WhatsApp groups, there are lots of discussion about the biosimilars, the botulinum, all these are being discussed. So basically it is all A, whatever we are talking, whether we are talking of Botox, we are talking of Dysport, we are talking about your Xeomin, these are all A. So switching from one A to the other, it makes no difference. It doesn't make any sense. But if you switch from A to B, in case there is any antibody production, then only you may have a different effect. In case the A is not working well for when you use it for some time, or you can use a biosimilar, which is much less cost. Like every medicine has come with biosimilars, right? So the Biogenin, which is being used by many people in the market, and they are getting very good results. Though I have never used it. Like Shubhra has mentioned, I am also sticking to one product. But in 3 of my patients, after long duration use of A, that is the botulinum toxin type A with the Botox, I had to switch over to one of the Biogenin that is only in one patient. And then again, I switch back to A.
So Botox comes in larger units, and how do you make it efficacious for the patient? Do you pool in patients? How do you do it? How do you store it?
Botox actually initially it came in 100 units, but now it also comes in 50 units. And whenever it is for the functional indications, like we use Botox heavily for the blepharospasm, hemifacial spasm, for the headache. So all functional 25, like 50 units. Okay. So usually one is sufficient. 50 units is sufficient for any of the function. But for headache, we go for 100, 150 units because that is the only FDA recommended treatment for headache. Okay. And for the cosmetic, like sometimes what we do, I usually keep it for at least a week. I have found that the efficacy still remains. And there is a paper, I think, Raman, I think you have mentioned, no? Like even the efficacy has lasted for 6 weeks. I don't exactly remember who has published, but they have shown that efficacy can last as long as 6 weeks. But the company people says that you should use it only one time and you finish it within the time and you need to pull in patients. But I have been using even for a week, like which I have preserved. I mean, keep it in the fridge, especially on the door. And after 1 week, till 1 week, I'm getting good results.
Yeah, typically 6 weeks is the timeline where you can use it. And if nobody comes, we can use it on ourselves, ma'am. Nothing to worry.
That's a good idea.
Any other question, Dr. Shubhra, before we go on to our next speaker?
No, ma'am. Any comments from Milind on this?
Not on the latter comment.
No, I'm fine.
So then we go on to our next speaker, Dr. Aparna Bhatnagar, who is going to be talking on filling the knowledge gap on fillers. And she's a senior ophthalmologist, trauma, orbit, and oculoplasty with a huge experience and working in Bill Roth's Hospital and has innumerable awards and honors to her credit. So let's hear from her.
Thank you, Dr. Chitra, for the introduction. And thanks a lot for organizing such a fantastic webinar today. And thanks for making me a part of this. Am I audible? And
Yes,
can you see my screen?
Yes.
Okay, so I will try to fill the knowledge gap on fillers in the stipulated time of 10 minutes, and probably advanced apologies if I overrun time limit. So our usual and useless fears and worries sometimes for youth and aging leads us to expectations, sometimes realistic and more so unexpected expectations. Having flawless skin, trying to imitate our role models, and we are always looking for something special that lasts longer and others can see the difference, but nobody knows. So the answers to all this could be fillers, which are actually called as liquid facelifts. And these are agents which work on facial surface volume augmentation. They have a function of contouring the face and also presenting emotional attributes to the face. They can be used either as standalone treatments or in combinations with other procedures like resurfacing, lasers, botulinum toxin. It's still not very sure whether which is an ideal filler, but manufacturers and companies are striving to compete and give best of best products to all of us. So wherever we are in our career and patient practice, we should be thankful and have gratitude to people who actually isolated these chemical substances, and now we have the luxury of using these in our private practice and in our practice. So the first in 1934, thanks to Mayer and Palmer, who isolated some chemical substance from cow's eye, and they named it uronic acid. But later they found that huge quantity of this sugar molecule was found in vitreous humor, hyla, which we call, and they named it hyaluronic acid. And it actually took 70 years for this sugar molecule to be approved by FDA as a dermal filler, which we use today. So if you see in the market, we have number of dermal fillers from hyaluronic acid to PLLAs to hydroxyapatite, and each one has its own pros and cons depending on how natural look they give and what is the longevity that they stay in inside the face.
Your
Aparna,
slides
so
are not moving, is it?
I'm sorry?
the slides are not moving. It's just the introduction slide.
Okay.
Can you see now?
You're seeing the first slide only.
Anna, either you switch off from the screen and share the screen again.
Aparna, is it on the full screen? Like,
Yeah.
It's not on the full screen.
not on the full screen.
Can you go to slideshow?
Can you see me now?
We can see you, Aparna, on the slide. What you do, you just close the PowerPoint and restart it.
Share the screen again.
Can you see?
Yes.
Yeah, go to slideshow.
Yeah.
No.
Can you
Not-
see now?
Go to the second slide because we can see the first slide.
Can you
And
see
we-
now?
No.
Okay.
Shari, can you guide us? Mr. Sharik, are you there? Mr. Sharik, can you hear me?
Aparna, is it moving on your own?
Yeah, yeah, it is moving.
No, it's not moving. You have to stop sharing and share again.
Yeah,
Or,
okay.
Use it as a PowerPoint.
Ma'am, I think it got stuck only. If you start sharing, it will come for sure, ma'am.
Aparna, open
Share
up
screen,
the-
no?
Aparna,
Yeah,
open-
click on share screen,
Yeah, yeah, I've done that.
and you have to share the screen which you want to show. Yeah, we're getting it, ma'am.
Now you
Okay,
should,
now do
Aparna,
it.
you should
Go
maximize
to
it.
slideshow. Yeah, go to slideshow mode, ma'am.
Yeah, it will move.
Click this, ma'am.
Click there.
Wait for a few seconds, it will come.
Can you see now?
Just
No.
give it.
No, I think she's given enough time.
Can you see now?
Aparna, can you scroll on the slider on the side and bring to the slide which you were talking about on the slider on the right side?
Did you try
Okay, wait,
sharing your
uh,
screen earlier on? It's so important. Should we go on to the next talk and come back to her talk? Okay, let's try.
Can you see now?
Yeah.
I
Yes.
think you can show like this only, ma'am. Don't do it full screen if it's giving an issue.
Again, you are not able to see, right?
No, we just see.
So we can see.
Can you see
ma'am,
now?
ma'am has clicked on PowerPoint show and that is not working. We can see your slides, our fears and worries. You
Yeah.
Yeah, can you see now?
Yeah.
can see the slide in the PowerPoint only. So you can operate like this only, ma'am, and go to next
Go to
slide,
the
like,
next slide now.
like Dr. Kasturi suggested.
Which is the slide that you can see now?
Our
What is
fears
the-
and worries. Don't do slideshow mode, ma'am. Stop slideshow. Press the
No, I'm
escape.
not doing slideshow. Okay,
Press escape key.
okay, okay, fine.
Or
Now-
we can go to the next speaker, and because
Yes.
this is taking time,
Sure,
no?
sure,
And
sure.
we can put it up, Aparna.
It's a very important topic. We need to come back to it. Dr. Anand, can you guide her?
I'm
It is
sure, Dr.
before
Aparna, if you can
I-
just restart your computer, will come out, find some application
Yes,
would
you
have
have
been
to-
open. In the meantime, the next speaker can take over and then we can come back to Dr. Aparna later on.
Okay,
You
okay.
need to shut down your computer, Aparna.
Shut
Okay,
down,
I'll
restart,
restart
it
it.
will be fine.
Sure,
100%.
sure, sure.
So we shall go on to the next session, My Ideal Choice in Ocular Aesthetics. And we have Dr. Shilpa talking on My Ideal Patient for Botox. And she is a senior consultant, facial, plastic and aesthetic and ophthalmic surgeon from Delhi Eye Center, Delhi. On to you, doctor.
Good evening, everyone. Thank you, ma'am, for your kind
नहीं, वो कह
words.
रहे हैं, restart करो पूरा computer फिर से. हाँ.
So, I'll be picking up from where Dr. Nidhi left. And when this opportunity of speaking at ARC AIOS was given to me to speak on my ideal patient for Botox, the first thought which came to my mind was patient who's willing to get a treatment and who's willing to shell few bucks is my ideal patient for Botox. But then I thought that I have to speak something for 10 minutes, right? Starting just a little bit about Botox, because when we say my ideal patient for Botox, we really don't mean Botox only, which is by Allergan. We mean botulinum toxin. So the type A botulinum toxin, which is the most potent, as Dr. Kasturi also mentioned, and the three major botulinum toxin A formulations which are available in the market and are most famous, Botox, Dysport, and Xeomin, are most commonly used. Apart from that, the type B myoblock is also used when it is required. And there are then many others, as has been discussed previously. Botogeny being the most commonly used, similar, I would say. So what's in a name? We have actually discussed this, so I'm not going into detail. Why I had put this here was because I'm going to use the application of botulinum toxin, and mainly why we want to study these different types of Botox is that because for safe clinical practice and to achieve optimal consistent results, as Dr. Shubhra also mentioned, we need to understand the clinical issues of potency, conversion ratio, and safety issues of each toxin available in the market. And as far as the key players are concerned, I would say Allergan is the key player, and I don't have any financial interest. Coming to choice of patients and my ideal patient, when to use botulinum toxin and why, when not. So the wrinkles on face, they do not look as cute as this on everyone, as we all of us know. So the facial rhytides, either dynamic or static, would need smoothing. We will not use the botulinum toxin where patients have peripheral motor neuron disease, amyotrophic lateral sclerosis, motor neuropathy, other neuromuscular junction disorders like myasthenia, Eaton-Lambert, in cases of pregnancy, areas of active infection at the site of injection, and any previous known hypersensitivity to formulation where we can change to a different formulation altogether if it is required. So reconstitution of Botox has already been discussed. I just want to mention here that if the vial is not open previously and the seal is intact, then while you're making and preparing the Botox, while it is reconstituted, the plunger will go automatically in because of the vacuum inside the vacuum seal. Dry package.
Mentally, physically.
Please
I would just
be
request
on mute.
Yeah. And after we have reconstituted the Botox vial with non-preserved normal saline and only normal saline, not distal water for injection, prepare your syringes. You can use tuberculin syringe or insulin syringe as preferred. Some pre-injection procedures. Do a thorough pre-procedure consultation with the patient as to what patient wants. Consent to the treatment, a written or a video consent will be preferable. And pre-procedure photography, because patients usually forget later how they used to look, and small changes which are previously there on right and the left side which don't match, they blame it onto you. They might blame it onto you, and record your treatments if possible. And general principles of injections, anywhere, wherever we are giving, upper face, mid face, or lower face, apply Prilox to patient's face around half an hour, 40 minutes before. Give ice treatment, which will decrease pain. While you are starting the procedure, clean with alcohol swab. Ask patient to animate always before the patient when you inject. Assess again, inject, avoid thin blood vessels so as to avoid any ecchymosis. And call patient back after 2 weeks, because usually it is then when the effect of Botox will be properly seen. Aftercare, I usually tell the patients not to lie down for 4 hours for the risk of spread of botulinum toxin. Don't rub or massage vigorously for a day. Don't do rigorous exercises, and don't use blood modifying agents. Don't take green tea, vitamin E, aspirin, etc. So patients who are having upper and mid face indications, usually will have forehead lines, crow's feet, glabular frown lines, bunny lines. When we need to do chemical brow lift of the eyebrow, and lower lid injections when it is needed. So we'll come to each one of them one by one. Here I'll be sharing few patient photographs. This is the lady. As we see here, she's smiling slightly as in static. And in this dynamic phase, we can see the horizontal forehead lines, the crow's feet, the wrinkles, and see the prominent nasalis here in this patient. Again, this lady in animation shows a single frontalis muscle. Here, the frontalis muscle is a broad base, we can see, and prominent glabular lines. Again, corrugators we can see very nicely here. And in lateral picture, the crow's feet are also seen. Again, this patient, when she smiles, the crow's feet are nicely seen. So customize the treatment. This patient does not need that much forehead Botox as this patient, and this patient on the right will not need nasalis injection, but this lady will need nasalis injection as well. Again, this lady has more crow's feet when she is not even that much smiling, and this lady has very less number of crow's feet. So the number of injections to be given here and the number of injections which will be given above the lateral canthal area in this patient on the right and the left will differ. Coming to horizontal forehead lines, as we all know, the only elevator of the brow is frontalis muscle, and it contracts and gives horizontal forehead lines which are perpendicular to the action of contraction of the muscle. So this is the basic rule. And here this lady again. Ask the patient to animate, inject into the belly. While giving frontalis forehead injections, just go in 2 to 3 millimeters, as there is frontalis muscle just below the skin and small thin subcute tissue. And do not inject a finger breadth above. Do not inject within the finger breadth here from the eyebrow, because it is the only elevator of the brow. And if we inject in all the right sides here, then patient might not be able to elevate the brow when patient needs to. So usually I inject above the first right eye which I see in the patient. Coming on to glabular lines. Sorry, I forgot to mention the dose here. So at each site, I inject 2 units and spaced well apart, because we have to consider the circle of diffusion of Botox, which Dr. Raman had mentioned nicely. And it's usually 1 centimeter. So you can initially in the practice mark also the points wherever you want to inject on the forehead. This is the usual pattern we mark the forehead in. Coming on to glabular lines, which are usually formed here in the center because of the action of procerus muscle here and the corrugator muscle on both sides. So the depressors of the eyebrow, the procerus and corrugators, will cause formation of 11s, the glabular lines. Pinch the muscle before you are injecting. Procerus is a thick muscle. When you go in a half needle length, you will be needing to go in to inject. After you go in, you can aspirate. Botox, if given in blood vessels, will not cause any harm as it's a neuromuscular toxin, but aspirate or just inject into the procerus here. Coming to corrugators, it has 2 heads, the superficial and deep. So for the deep head, which is medially, one would need to go whole needle length in and inject. For the superficial head, go in a half needle length and inject. And if you ask the patient to animate, you will know how the corrugators are placed in that patient. So corrugators can be placed like this in this manner along the eyebrow, or they can go run up also at an angle of 30 degrees to the eyebrow. Coming to the crow's feet, the action of orbicularis repeated over years will lead to crow's feet here near the lateral canthus. And if, as I had mentioned before, if the crow's feet are more above in this area, just inject above. Otherwise, inject below the lateral canthus and above the lateral canthus, both. In this patient, I'll be just needing 2 injections for the crow's feet. Again, of 4 units at both the sides. For glabella and for that is for Procerus corrugator, I had injected 4 international units at each site. Bunny lines. So the ones which are formed because of the contraction of nasalis muscle. I'll be showing you this video after a while, because while I was incorporating it into the slideshow, it was not getting fairly well. So inject for nasalis here. Either you can inject in the center, 4 units either on each side. I usually just inject either on each side. So coming on to lower face injections for botulinum toxin. The muscles on the lower face, most important here around the lips, orbicularis oris, will lead to perioral area wrinkles, marionette lines here, and masseter hypertrophy is a very good indication of use of botulinum toxin in the lower face, as well as platysmal bands in the neck. For perioral lines, these are the points to be injected. Inject superficially, do not inject deep. Inject 2 units each, not at the wrinkle, just in between the wrinkles. For dimple chin, we would need to inject in mentalis. For this also, I'm going to show a video later on. And I usually inject 4 units on each side of botulinum toxin for this pseudo-orange appearance of the chin. Again, for platysmal bands, we can inject. Either we can hold this platysmal band and inject into the platysmal band, or just inject without holding it. Either ways it would work. Inject superficially into the bands at multiple levels, 2 units at each point.
Should you be concluding? I think your time is running out.
Yes, ma'am. Yes, ma'am. So inject as the anatomy dictates. Just beware, because injecting Botox not properly commonly can cause Spock eyes. When we inject the forehead here and the lateral muscle is unopposed, it will lead to Spock eyes. It can lead to upper lip asymmetry if zygomaticus major minor are injected, lower lid ectropion, ptosis, brow ptosis, and don't completely paralyze the only elevator, which is the frontalis. It may also cause chipmunk faces, where there is this appearance of unnatural resting face. If we have injected very low down in crow's feet area, this fat bulge will be seen lower down and the cheek will appear low, as in chipmunks. These are few pictures of my patients who have had combination treatments, because Botox alone would not work so well and patients would need good results. So I would want to say that if you use judiciously with proper techniques, Botox is definitely a wonder tool. And I would like to conclude by saying that my ideal patient for Botox, a patient who is self-motivated, who comes to you, we are able to counsel the patient, is ready to look good at a certain cost, both material and emotional, and understands the limitations of the procedures. Thank you, all of you.
Thank you very much. Thanks. A wonderful talk. Just have 2 basic questions, and I'll take one with Dr. Millen. Now, when you give these injections, which part of the face has more predictable results?
All parts have predictable results, ma'am. Botox usually is used for upper face and lower face. Mid face usually doesn't have those many indications as such.
Dr.
If
Millen?
we-
Yeah, I would agree. Upper face is the most predictable, and the indications are also most popular, especially for an ophthalmologist. Mid face and lower face relatively less. I usually stick to the upper face. With,
And how do you deal with the pain component to make it less?
Well, pain part, you can either use prilocaine cream, which we also use for injections when we do the facial spasms. You can also use ice. I find cream application 20 minutes prior to the injection quite useful for patients. But frankly speaking, many patients are not willing to wait for those 20 minutes, and they don't mind being pricked with a fine needle. So pain is usually not a concern with at least half of the Botox patients.
Dr. Shukla?
Yeah, ma'am. So coming to like the areas of indication, as aptly said, for ophthalmologists, upper face, but in my practice, I'm doing a lot of mid and lower face because that's where the major contouring happens. You can take care of expression lines on the upper face, but if you really want to contour the face, it's the mid and lower face which works the best. Regarding the pain, I think, yeah, those are the tricks. You know, I usually give Prilox or Prilocaine to people. If I know that the patient is coming on a fixed date and time, I just ask them to buy the cream, apply at home, come and, you know, just inject and send them. And along with that, I think fine needle, ice, everything works together. Also, I think I would just add and ask Shilpa on that. Shilpa, which needle were you using, number one? And number two, I just saw your video of the upper face where you were injecting in a direction which is usually, you know, I saw it where being injected in a different manner. So do you have a specific reason of why you were injecting towards the eyebrow on the forehead versus what we usually recommend is in the direction of the muscle, perpendicular to the muscle? Was there a specific reason for that?
No specific reason, ma'am. Just for this patient, the patient was at 45 degrees angle on an ophthalmic chair and I was standing on the head end. And plus, when we inject, if we leave the one finger breadth above the eyebrow, usually the diffusion circle is not that much to diffuse to all the unwanted areas, I must say.
Mm-hmm. So, and which needle were you using?
I was using 26 gauge. And like when I'm using a 1 ml syringe, 26 gauge comes with it. So I usually inject with 26 gauge. And when I'm changing the needle, I just shift to 30 gauge when I refill the syringe. So this is what I usually do.
Okay, so coming to the pain question, I think it is very important to use the right needle in addition to the technique which is being used. I find 26 gauge needle is more painful and difficult to penetrate, especially in a thicker epidermis, because most of the patients, especially the male members, have thick epidermis. So it is difficult to penetrate. And coming to the diffusion circle, just for the interest of the audience, and Dr. Kasturi, Adit, anybody who wants to add, Milind, please add. 1.3 square centimeter of diffusion circle will always be there, no matter in what area and how you inject. But I think the key here is to stay perpendicular to the muscle and you massage in the direction of the muscle. And I think for Botox, if you don't aspirate, it's fine, because when you aspirate, you already are with a fine needle in a small muscle group, and you may actually kind of, you know, deviate from the path where you're injecting. So these are just fine tips which can actually make the process very comfortable for the patient. But everybody has their own ways and techniques, so nothing right and wrong, which is some of the observations which I thought I would share. Dr. Kasturi, Ellen, Adit, please add on to the things. Yeah, Shilpa, you can go on.
I would like to add something on the pain part. So pain actually happens when the spread of muscle happens after we have injected Botox. The pain of prick is usually very less. We can eliminate the pain of prick by Prilox as well as the ice packs, but the pain which will happen once the Botox goes inside the muscle, no one can decrease that pain unless the patient is under GA, I feel. So, and we are not going to do this procedure under GA. So, as Dr. Chitra asked, the pain part is mainly when the Botox goes in and not when the patient is pricked, actually. This is what I wanted to say.
And these unwanted side effects is largely because the plane of injection is wrong. You need experience. These don't happen once you have reached a level of expertise.
Ma'am, after reaching a level of expertise, also they can happen because once you are so confident that nothing is going to go wrong, then only the things start going wrong. Initially, when you're doing everything according to rules, usually things will go right.
Okay. Any other question, or shall we go back to Dr. Aparna's talk?
I just wanted to tell you about the type of needle which I used. I definitely use the smallest size, which is on the insulin, which is the insulin syringes being used for injecting insulin rather than this tuberculin syringe. Yeah. Even this 30 gauge needle comes with a hub. So there's a lot of amount of approximately 0.6 ml, 0.06 ml goes waste inside the hub of the needle. So when you inject with the insulin syringe, the needle size is very less small, the gauge size is smaller, and you don't waste the insulin, the Botox. So I use those red syringes, which are meant for insulin injections.
So while that Botox is left in the syringe, if we aspirate little air and then inject, the Botox will go in and air will stay in the syringe. So that way we can stop wasting Botox in those syringes. This is what I've experienced.
So shall we, you have a same problem or you're good to go, Dr. Aparna?
Yeah, okay. Ma'am, can you see the slide?
Yeah, we can see the first slide, introduction slide.
Okay. Can you see my next slide?
No.
Oh God. Oh God. Can you see now?
Oh.
No. So I restarted everything again.
Ma'am, please
and it
stop
says,
sharing.
I'm sorry?
Stop sharing, ma'am.
Okay, I have stopped sharing.
Now, when you click on share screen, what do you get?
Yeah, so I'm getting share screen.
Yes, ma'am.
And so I have two windows open.
Yes, ma'am.
No.
What do you share, ma'am?
Okay. Can you see now?
Yes, ma'am. Now don't click anywhere, ma'am. Don't click anywhere. We can see this. Now go press your down arrow key, ma'am. Keyboard down arrow key. Don't click there, ma'am. Keyboard से down arrow key.
नहीं हो रहा.
हो रहा है ना मैम, ऐसे दिखा दीजिए.
हो रहा है. Now
ऐसे ही दिखा दो.
ऐसे ही दिखा. There is no choice, ma'am, because what you do is you go into slideshow mode and your computer is not able.
I know. I think yeah, it's not getting that.
So it's better you show it this way.
Fine.
Don't click anything. Just use the arrow keys, ma'am.
Now can you see?
We can see that. Yeah. I think we can manage.
Okay. Perfect. Okay. Thank you and apologies for the glitch. So I'll cut short my presentation. I'll just directly go. Yeah, so talking about fillers, they are liquid facelifts, which are used for facial and surface augmentation, volume augmentation, and also they have the potential to change the emotional attribute of a patient. They can be used as a standalone treatment or in combination with other procedures like lasers or botulinum toxin. So we are still not very sure if we do have an ideal filler around, but the marketing companies and the manufacturers are in the race to give us the best. Wherever we are in our career and practice, we should not forget the people who actually made these molecules available to us, and we are using it as a luxury. So in 1934, biochemist Mayer and Palmer isolated an unknown chemical substance from cow's eyes, which they called as uronic acid. Further investigation found that this was a sugar molecule which was abundantly found in vitreous, and so they named it as hyaluronic acid. And it almost took around 69 to 70 years for hyaluronic acid to come and be approved as a dermal filler, which we use today. So dermal fillers are of various kinds, and depending on the longevity, the pros, how most natural looking, and what mechanism they have. So this ranges from hyaluronic acid to PLLA to PMMA, we are very well aware of. And fat transfer is the oldest skin augmenting material. It is the longest lasting type of filler, but it requires an invasive type of surgery. That is the down part. So if you talk about the armamentarium in aesthetic practice, my approach is more of a holistic approach, where one needs to have a thorough knowledge about the anatomy, the vasculature, and that is why, because we are dealing with danger zones and danger areas of the face, including the vasculature. So very thorough knowledge about the danger zones of the face should be there. Also, face mapping, surface markings is very important. And in past, we have had some fantastic workshops organized by Dr. Kasturi, Dr. Milind, Dr. Shubhra, Dr. Devraj, where they taught us the pearls of aesthetic practice using dermal fillers and the tips and tricks of getting a good aesthetic result. And I'm sure we should have more of these workshops in future. Coming to techniques, yes, there are more than 4 to 5 different techniques, and it depends on individual clinicians and surgeon. And also we should know the know-how as to which part of the face would receive which type of a technique. Also, there has been a controversy regarding use of needle versus cannula, which part of the face needle is better because it is sharp, straight, and it goes subdermal or till the bone level, versus cannula, which is more superficial but better transmissibility of dermal filler. So we should also concentrate on the areas to look out for. If it is just a small line, we need to lift it up, or a superficial or a deep wrinkle, which we are addressing to smoothen it out, or areas like perioral or lip area, which we want to pump it or plump it. So we have certain medical codes and equations for these features, like the MD codes, which we said. It's a system which provides specific injection guidelines. And it also gives us the location, the layer, the type of tool, the delivery system, and it tells us how much volume should be injected on each side to achieve optimal results. And this is regardless of patient age, gender, or ethnicity. So if you look at this face, it has coding systems generally by letters, alphabets, or numbers. For example, cheek is denoted by CK. So we have CK 1, 2, 3. Jawline, J, or tear troughs denoted as TT. So a sequential approach, if for such patients, we denoted for like an architectural principle of FCR, where F is foundation, C is contour, and R is refinement. So just like a house which we build, the main important part is foundation, or laying the foundation or the base, then contouring it with formation of floors, walls, etc. And finally beautifying it with refinement using an interior decor. So the same thing happens when we deal with patients. So suppose a patient comes to us with a made face sagginess. So just trying to correct the tear trough will not be the perfect solution. So we need to look at the foundation, which is addressing the lateral or the vertical lifting vectors, the contours starting from the temples, going up till the upper cheek, the mid cheek, mid face, chin, and jawline, and finally refining the entire face by extinguishing the lines and the folds. So this is something that we should keep in mind. And so as aging process, we can see that it does not occur uniformly in all areas of the face. Similarly, we need different fillers to be addressed for different parts of the face. So not one rule applies to all. And so the main question is, which filler do I need, or which filler should I use? So it depends on individualistic approach of the clinician giving that. Today we have a flood of numerable dermal fillers in the market, and sometimes it may be confusing because each of the company people come and try to boast their products on our heads. And if you see the future or the new products in markets, they are actually experimenting with each and every molecule. Like hyaluronic acid right now comes with antioxidants. They are even trying to combine two different dermal fillers like hydroxyapatite with hyaluronic acid, or they are carrying a CMC gel carrier along with the dermal filler. So coming to the indication, aesthetic indications, I think we'll have a lot of discussion in this webinar. So I'll just put in a small word about the functional, viable non-surgical alternative to dermal filler, where they actually improve the quality of life. So for example, this patient, she's a TRO thyroid patient, and she did not warrant any orbital decompression, but she just wanted a little bit of lift for her lower lid. Plus, she had a mild amount of tear trough deformity also. So just putting a mild dose of dermal filler into her lower lid would help a little plumping and lifting up of the lower lid, which she actually wanted, and that improved the quality of life for her. Or in certain cases, very rare cases, we can combine dermal fillers post surgical deficit if we have any. Or what I've heard Dr. Kasturi also speak about in previous webinars is something called as a myomodulation, which is a non-invasive, and we kind of alter the muscle function by putting or injecting a dermal filler in between the tissue planes of the muscle. And also as combined procedure, if the patient has just pigmentation, appeals would do as our dermatologist colleagues do, followed by filler. Or if the patient has only skin sag, they can go for a RF followed by fillers. Or if the patient has wrinkles, as we talked about, Botox and fillers are the perfect combination. So like we look out for giving the best result to the patient, we should also look out for reducing the number of complications, because that is where the problem arises. The person, we are living in a consumer aggressive era, and we are on double sword edge, because here we are trying to give the patient the best, but sometimes the patients are not satisfied with the result. And also in India, especially beauticians, cosmetologists, and other unlicensed individuals, they illegally administer dermal fillers. And when the patient is dissatisfied and comes to us, he doesn't have a proper record. So in this case, we can land into trouble. So while going through literature review, found an article which says that MRI is the best reliable tool for such cases when you have a medical legal problem. Why MRI? Because dissatisfied patient and an MRI can be used to provide an objective evaluation of fullness, symmetry, and the level of injected dermal filler. Also, we can look for other problems like migration or abscess formation or granuloma. So interestingly, I found that various dermal fillers actually behave very differently on an MRI. Like for example, collagen, if you take an MRI post-contrast or post-gadolinium, it will behave as a hyperintense signal. At the same time, polyacrylamide, which will show not much hyperintensity, change in intensity, pre and post-contrast. At the same time, silicone dermal filler will look like a individual oil drops, which will be more prominent on fat suppression. So if we are not sure what the patient previously had which filler, an MRI will be a good tool. Similarly, for hyaluronic acid, if we take an MRI, it will show a very well-defined serpiginous margin. But if you take the MRI of the same patient, maybe after 4 to 6 months, the intensity will lower down on the same fat suppression, on the same post-contrast medium, but it will also show vascularization, which is very, very typical of hyaluronic acid dermal filler. So medical legally, again, consent and documentation cannot be underemphasized. Have a proper bench time with the patient. Pre and post photographs, treatment photographs are a must with a separate consent. And also discuss the asymmetry with the patient before going for the treatment protocol. Cost is another factor which is very, very important in our country. And face sketch, we can go a proper documentation of face sketch, because sometimes what happens, the patient who had a dermal filler will come back to us with he needs to have something else like a radio frequency or a dermabrasion or a peeling done. So this will help the dermatologist or even us to kind of find out where the dermal fillers were given. So I have my own set of separate consents for medical photography for every patient and a separate for dermal filler treatment. And so finally, during this pandemic, no webinar talk can go without talking about corona and COVID infections and association with fillers. So many of our patients come to us with questions like, should I get fillers if I had a COVID infection? Or should I get a COVID vaccine if I had a dermal filler? Or which is better, Botox or filler after a vaccine and I had a COVID infection? So what to do? Which is a safe vaccine if I already had a dermal filler, and so on and so forth. So while going through literature review, I came to find out that there were some reports published showing a kind of hypersensitivity reaction to dermal fillers post-COVID viral infection. So this one is from Dr. Debraj. He published this paper in 2021 May, and this shows a lady who had undergone a dermal filler in February 2020. She was quite happy, and then she got infected with COVID, and then 8 months later, she developed a mild erythematous edema reaction over the place where she had dermal filler. Again, 2-3 more case reports have been found, have been published, which show filler hypersensitivity post-COVID infection. So various cases have been published, but the striking point is each of the patient had erythema, edema induration over the areas where they had previously the dermal fillers, but it typically occurred 3 weeks to 4 weeks after they got the COVID infection. Not only COVID infection, fillers and hypersensitivity has also been found in post-COVID-19 vaccination. So first report came out in March 2021, where Moderna vaccine clinical trial, there were 2 participants who had previously hyaluronic acid facial fillers, and they experienced a little edema of the face and lips after their shot. And likewise, similarly, after a year or so, Pfizer came out with another paper showing that their patients also had similar hypersensitivity reaction to dermal filler post-vaccination. So all this important thing what to find or what was noticed in these papers was that the first shot of vaccination went uneventful. All the patients who had dermal fillers earlier, but the moment they took the second shot, they had this kind of a reaction, which actually subsided with or without any anti-inflammatory treatment. So the main question is, today we are still giving dermal fillers post vaccination or in this pandemic era. So do COVID-19 antigens or vaccine, do they really cause some hypersensitivity to dermal fillers? And the answer is yes. But the good thing is that they show a delayed type of hypersensitivity, which is mostly, it is only being reported with people who have had hyaluronic acid filler. It's a T lymphocyte mediated, occurring anywhere between 2 days to weeks or months, and it usually resolves within few days. And so the incidence rate has been also reported way below, like it's 0.3 to 1%. And lastly, if I have time, I would like to just mention something about dermal fillers and regulatory laws in India. What we know and what we need to know, I'm sure many of us will not be knowing. As busy practitioners, we don't have the time. Most of us are not actually familiar with the regulatory requirements for drug approval and procurement. And so the question comes, if we have an adverse event with our patient, where and how to report? Also, aggressive marketing by these manufacturers purchasing their FDA-approved device is also on the move. The main problem in India is online vendors, they sell products very cheap. The cost is a major issue in our country. And so substandard, dubious quality or expired products are in full form available online, and many patients come to us with their own online bought dermal fillers, and they force upon us to use their products. So also at the same time, very unfortunately, some physicians are providing on the social media their testimonials about the benefit of such fillers, which should not be there, which we should kind of rely on our own clinical effectiveness and experience and safety data rather than trust on a particular brand. So surprisingly, in India, there was no medical device regulation before 2005. And the main drug controller general of India, that is the DCGI, came into existence only in 2013. And finally, it was merged with the Ministry of Health and Family Welfare in 2017, which they formed the medical device rule. And interestingly, all the dermal fillers available in India continue to be designated as medical devices and not aesthetic drugs. So if you see soft tissue fillers here in India under MDR 2017 come under class C of moderate to high risk aesthetic devices, medical devices, what they say. And hyaluronic acid filler is the only filler approved in India. Other fillers like Sculpta or hydroxyapatite products are not approved in India as a soft tissue filler. So we need to kind of
And
look
you have
into.
1 minute remaining.
Yeah, I just finished. So the only important part we need to remember is there are some laws amendments done, and from this January 22, every medical device, including our soft tissue fillers, will now bear a unique device identifier number, which is basically a global trade item number. So even if you are importing a filler, it will have that UDI number and a tracking device, a tracking system, which we can track as a pre and post marketing. So the possibility of getting a dubious or a counterfeit or a substandard or expired product is going to be minimal. I hope so. But for our clinical purposes or on an individual level, if we find any adverse event, we can report that event directly to Sri Chitra Tirunal Trivandrum. Or instead of reporting it to the manufacturer or the vendor, because we are not very sure whether our complaints are carried forward to the company. So with this, I would like to wrap up. I would like to acknowledge my dermatologist colleague, Dr. Shweta Rahul in Chennai. And thank you so much. Be safe.
Paucity of time, we'll have to move on. But what little I understood was the choice of a product of filler depends on the amount of volume you want to inject, or maybe the thickness of the skin, or the laxity of skin, or age and all that. I did not get clarity on that part, like which would you choose for which kind of defect. Maybe in the subsequent talks, I would want to hear. But knowing that these changes are irreversible, do you have any kind of an antidote to deal with this?
Yeah, so antidote in the sense that there is a product called hyaluronidase, which suppose we have done a patient where we have overfilled that particular area. So we can kind of disintegrate that hyaluronic acid by using the hyaluronidase enzyme, which is, as you said, it could be an antidote. So the moment we feel that it has, we'll wait for some time for the filler to act, and with massage many a times, even if we have overfilled, with massage, proper massaging, at that point, we can readdress the filling with the gap in the tissues. But after a point of time, suppose many patients, they are not satisfied, they see a little bump or a lump here and there, we can inject hyaluronidase to kind of disintegrate the collagen, the acid sugar molecule, and then we can re-massage it. And this is one specific antidote which we have.
Dr. Shubhra, anything to ask before we go on to our next speaker?
No, I think fillers is an elaborate topic, ma'am. We can have discussion on and on. I think for the paucity of the time, let's move on because we have wonderful star speakers waiting in the queue.
Yes. So we have our next speaker, Dr. Adit Gupta, who's going to be talking on my ideal patient for fillers, and is a very young, dynamic guy, specialized in oculofacial plastic and reconstructive surgery, practicing in Bansal Vision Institute, Maharashtra. So on to you, Dr. Adit. Can you share your screen?
Yeah. Is my slide visible now?
Yes, yes.
So at the onset, good evening, everyone. I would like to thank Team AIOS ARC for giving me this opportunity. And actually, Dr. Aparna's talk was the perfect prelude to what I would be discussing. I was told to speak upon how to choose the ideal patient for fillers. Now, this itself is like a big topic, which I would divide by speaking about how to screen an aesthetic filler patient, how to do an assessment of a filler patient, certain clinical scenarios, and which patients to avoid. Now, rather than speaking on how to choose the ideal patient for fillers, it is the other way around, mostly in our practice, where we try to screen the patients who might cause trouble in your practice, especially while dealing with these patients. And as Aparna rightly mentioned, that the doctor-patient relation is now slowly, because of the Consumer Protection Act, turning into doctor-client relation, which is causing a lot of trouble. And a lot of these cosmetic patients who walk in don't want to be called as or addressed as patients. So medico-legal aspects are cropping up. But if we look into how to choose an ideal filler patient, we need to understand that although we are ophthalmologists to begin with, in surgical subspecialties like ophthalmology, we have certain objective outcomes to look at. Like after a cataract surgery or after a LASIK refractive procedure, you would look to achieve good vision where we can objectify it by reading the Snellen's chart. But aesthetics, on the other hand, is more about experience and emotion. In many cases, we all get shocked that the objective outcome is not important, but understanding the psychology of a patient is the key to a successful aesthetic practice. I would give a very small example to begin with. This is one patient who came to me early in my practice when in 2017. She was basically a hyperthyroid patient, had lost a lot of weight and complained of looking sad and losing a lot of fat on her face. So on the first visit, I suggested her to go slow and go ahead. If you look, after 4 cc's of hyaluronic acid fillers in the middle photo, you can see there's not much change. I personally wasn't very happy. There's not much change, but the patient was ecstatic. I don't know why she was ecstatic, but she stuck on to me. And this is after 3 years of follow-up where I've almost injected 14 cc's of filler into her face, maybe because of hypothyroidism. And now she certainly seems to have settled in and has a result which is better than how she began with. But this patient has stuck on to me, comes to me every 6 months and get fillers done. Although I personally don't see that magical effect in her. So this is what made me wonder that how do you choose your ideal patient? Now, becoming a competent aesthetic physician or a surgeon is a yellow belt if you relate it to karate. But when you start understanding who to take on as a patient and when to say no, you achieve the brown belt. But a black belt is only achieved when the patients whom you have said yes and where you understand what makes them happy. Now, screening out a filler patient is how you want to say no. There are certain warning signs which you see. One is if the patient turns out to be very manipulative and talks differently to the staff and then talks differently to you, calls you by your first name without your permission, is excessively manipulative, charming, and fawning, and has unrealistic expectations. Secondly, if the patient keeps on pointing out flaws of other physicians whom they have seen, but you, on the other hand, are the most wonderful doctor that they have met and they try to persuade you into doing certain treatments. Third, you would not want to touch a patient who is extremely depressed or anxious, and a patient who pays excessive attention to details, like would get a mobile phone and show you certain pictures and try to tell you to emulate these pictures in their body parts. You also pay attention to your staff because staff is your best friend. They tell you how the patients behaved with them in the clinic. And then there are certain soft warning signs where the patient tells you that she has a big wedding coming up next week, or talks about finances all the time, or is fixated on a specific procedure which might not be appropriate to them. So all these things are the psychological aspects of how to decline and when to decline a patient. So these are the aspects where you don't want to choose these patients for your procedures. Now, this is one very major aspect which comes into our practice. This is a case scenario where a 40-year-old musician came to me because she did not like the shape of her eye, and because of which she stays home, uses glasses, cannot get out, brings a lot of marked photographs, gives history of multiple surgeries, but clearly enough doesn't want to disclose the name of the surgeons, and has tried fillers as well and is unhappy. Now, it is obviously written on her face that this is a clear-cut case of body dysmorphic disorder. So this is a very common disorder that you need to screen out in your practice. These patients are severely narcissistic. They have an unrealistic view of themselves, are addicted to surgeries, and begin very young. And if there was a study in the US which concluded that you see in oculofacial plastic surgery, almost 6 to 7% of these patients that you see in your clinic would turn out to be some grade of body dysmorphism. Now, you don't need to screen all of them out, but the severe body dysmorphic disorders need to be really rejected and not provided any form of treatment, because it's just a chain reaction. After you, she's going to go on to another physician. Now, is there an ideal filler patient? I think ideal filler patient is a myth. Rather, you can have a happy filler patient, and there's a very fine line, and you need to strike a balance between an ideal and a happy filler patient, and you need to look at how you can make these patients happy. Now, in ophthalmic practice, usually patients that we get as referred by ophthalmologists, apart from dermatologists, are post-LASIK patients who uncover their glasses and notice blemishes in the under eye region. young patients who have genetic under eye problems, post-blepharoplasty patients who have hollowing, and then there are functional issues like eyelid retraction, which Aparna has already pointed out. Now, in the ophthalmic subspecialty, usually you would want to do fillers and focus on fillers in the eyebrow unit, the temporal fossa, the upper eyelid sulcus, and the lower eyelid mid-face complex. Shubhra has also mentioned about complete evaluation of all these patients. So it includes also looking at the skin quality, texture, extent of volume loss. You don't want to promise a patient like this magical results just with filler alone. She will need a lot of combination therapies. So you need to know about that as well. You need to screen out fluid retention in patients because these are strictly no-nos for filler injection. Fillers are hydrophilic, so they attract a lot of water and cause more fluid retention. On the other hand, a young patient with good skin quality, a little bit of tear trough hollow, is the ideal patient for a tear trough filler as seen in this picture. You need to know your anatomy very well. There's the orbital rim hollow, the septal confluence hollow, and the zygomatic hollow. Usually the tear trough defect is at the orbital rim hollow, and this is the defect most commonly filled during a tear trough filler injection. Now, coming to case scenarios which are ideal for us as ophthalmologists to deal with, Dr. Millind has published a paper about how post-refractive patients need to undergo photography without their glasses before undergoing a refractive surgery, because a lot of them attribute these under eye circles and darkening due to LASIK surgery. Now, this young lady was referred to me because after her LASIK surgery, she noticed under eye dark circles, and it was just a case of pseudo dark circle where she had a little bit of fat prolapse, and just with 1 cc of filler injections, we could achieve a good result. And once you make these patients happy, they keep coming back to you for further indications and further cosmetic therapies. Second case scenario, which we very often deal with, is a bony hollow. Now, these are purely genetic defects. These run in families. These are typically young patients with a deep tear trough deformity due to bony architecture, as well as loss of soft tissue. These are ideal patients for filling as long as their skin quality is good. I'll come to that later. But these patients can be very well dealt with hyaluronic acid fillers. Just 1 cc usually suffices. If you need to treat the mid-face, you can do it as a conjunction. But most of the patients are usually happy with these filler injection results. I'm not showing the video due to paucity of time. Third scenario, where you can camouflage a particular grade of eyelid bags with filler injections, is where there is mild to moderate fat prolapse, where the patient is not ready for a surgery, has a good mid-face architecture or profile, and has good eyelid tone. Because when you're adding fillers to the eyelid, you're adding weight to it. You don't want to do fillers in a patient with gross ectropion or gross eyelid laxity. So obviously, moderate fat seen in this lady, you can camouflage it with a filler and get good results and avoid a surgery for the time being. On the other hand, such patients who are on the edge can undergo surgery as well as filler injections depending on their choice. This patient underwent a blepharoplasty surgery, so the results are not different from a filler injection. Now, fillers can also be used as a combination in such patients where she has an upper eyelid hooding or dermatochalasis, which was corrected with a upper eyelid blepharoplasty. But she also has a deep tear trough along with little bit of skin thinning. So this patient underwent a combination of upper eyelid blepharoplasty with a lower eyelid Restylane or a hyaluronic acid gel filler, and this is the result for you to see. So combination therapy is also a good option when you want to deal with a patient who has multiple issues that need to be sorted out. Last but not the least, we should not leave the eyebrow away. Most of the patients, especially beyond the age of 50, undergo eyebrow fat pad deflation, which causes drooping of the eyelid skin and the eyebrow beneath the orbital rim. Such patients can undergo a blepharoplasty combined with a little bit of eyebrow filler injection. We have published about this, our experience with eyebrow filler injections. This is usually done in the retroorbicularis fat pad or the eyebrow fat pad, which gets inflated with the filler injection. It is a very safe injection, and it's very commonly seen, as Dr. Kasturi would agree, in Northeast Asian or Asian patients who have a type of sulcus deformity, which looks very good when filled.
1 minute remaining, sir.
Yes. Last but not the least, functional patients like thyroid eye disease, which already Aparna has covered, can be treated with hyaluronic acid gel fillers. Usually we try to treat with hyaluronic acid gel fillers if there is an aesthetic concern in a burnt out thyroid eye disease with a tight eyelid, or if there is some sort of exposure. Usually I don't treat patients with proptosis with fillers. Only pure eyelid retraction patients can be treated well with filler injection. After looking at the psychological aspects and ideal case scenarios, we also need to know whom we should not touch clinically. Now, this middle-aged lady has came to us with under eye concerns. You can see that she has a teardrop deformity, but there's a lot of pigmentation as well. Now, under eye pigmentation is a very difficult subject to treat. There have been a lot of creams and under eye treatments which have come, but most of the under eye pigmentation is very resistant. Sometimes it could be associated with systemic conditions or increases after pregnancy or after hormonal imbalance. Now, this young lady who was treated with under eye filler when I was early in practice, you can see that she kept coming back to me complaining that there is some sort of pigmentation still left, and the pigmentation sometimes gets unveiled after a filler injection. So you need to be very careful while injecting this. Secondly, you need to be very careful while injecting patients with malar edema. So she had a little bit of malar edema, which maybe I missed on my first examination. And these are the patients who have a rough course after an under eye filler injection. They keep troubling you. You have to do a lot of hand holding, and eventually it takes months sometimes for this under eye, for this fluid to settle down. She still has a little bit of persistent fluid. Also, these patients could be the patients who have hypersensitivity and fine skin where you can see a little bit of Tyndall effect from the filler. Last but not the least, Aparna has already spoken about this, but some patients are allergic. Now, this young male came to us, and this picture which I've taken on the left-hand side is after application of topical prilocaine. You can see that his skin has turned a little boggy after application. So this is a sign that I shouldn't have missed. He has a teardrop deformity. At 1 week, he looks very good. But when he comes back at 1 month, he's very unhappy because he has this sort of hypersensitivity reaction, delayed kind, and also a little bit of hyperpigmentation in the teardrop area. So these are the certain signs which you need to look at and sort of be careful. Obviously, this can be dissolved and reversed, but you don't want an unhappy experience for your patient. So to summarize, you should screen all your patients for body dysmorphism when you're dealing with a filler patient. If you are not confident, or if you think that the patient is oversmart, you should try and send them to your competitor. Triage these patients as to whom you want to touch, whom you don't want to touch. Avoid fillers in patients with fluid retention and allergies, frank allergies. And also the patient who understands the need for repeat injections, because the effect of fillers lasts for around a year or so, depending on which area we have injected, and understands the economy of these procedures. Thank you.
Wonderful talk, Dr. Adit. Dr. Shubhra, you have some questions to take?
So I think Adit has very well presented and covered the periocular concerns, including the pigmentation, teardrop, and the cheek hollowness, and how to choose the ideal patient. I think that's very, very aptly put forward. Adit, I have just one question. Now, suppose you have a patient who comes to you with unrealistic expectations. How do you tackle such patients in your practice? And most of these patients would have done the doctor shopping, and you would be one of them. So yeah, how do you actually do the counseling and take it forward?
So I think when we are tackling an unrealistic patient, the most important thing to understand is that we have to be, the patient and the doctor or me, I have to be on the same page. So if the patient is not on the same page with me, especially if you see a lot of these patients who are actors or models, these are the patients who trouble you the most. They want you to inject according to their fancies or where they want the filler injection. So such patients, usually if they are not amenable to my treatment plan, I usually frankly deny them, or I just gently, politely decline and tell them that I'm not the right doctor for you. You can choose to go to any other qualified doctor. If they are amenable to my plan and if they don't have unrealistic expectations, then I go step by step. So I try and see if I can sort of make a plan over a period of 6 months and tell them that let's begin with 1 syringe. If you like the effect and you want to stay with me, then you come back to me after a month or 2, and then we can go ahead in a graded fashion. So I usually try to delay their treatment or try to assess their treatment over 2-3 visits. If at any visit I think that I cannot fulfill their expectations, I just refer them. But all said and done, I think the most important thing for us to realize is that we should never, even if the filler injection or whatever procedure has been done is not up to the mark, we should try and avoid speaking about the earlier doctor, because sometimes it might fire back upon us. So that is one thing which I avoid whenever I deal with such patients.
Nicely put, Adit. But in my experience, and I would ask other panelists on board to have their experiences being shared here. Actually, more and more what I see is these patients who are difficult patients turn out to be your best spokesperson if you deal with them properly. Yes. So I think, yes, your moderate dysmorphic syndrome patients definitely have to be wooed away and to be handled carefully. But if you have a difficult patient, and I mean, difficult in the sense of the indications and the experiences they ever had, and if you handhold them and take them slowly, I think they become your best candidate. So there is always a thin line of understanding who's your ideal patient and who's not. Yeah. And I would like to have inputs from Dr. Bilin, Dr. Kasturi, and others on the panel, please.
Hey, Shubhra, hi. Well, as long as the patient understands the science behind the complexity or the complication, I'm okay to do the hand holding. Once they start getting unrealistic, I follow the same strategy of sending them to the competitor, or just letting them know that there are other people who are more experienced than me and they should take a second opinion or a third opinion.
Kasturi, anything to add before we go on to our next speaker? I think we're running short of time.
I exactly try to put myself in their shoes. This type of patient, sincerely speaking, I feel very sad. I really want to help them. And very recently, there was a child who had this problem, and he had visited many places, different parts of India, and I feel so sad. I really spent hours and hours with him and tried to understand his psychology. Ultimately, he was not happy with his eyes. He felt that one is bigger, one is smaller. And ultimately, with multiple discussions, I had done the procedure. And, he was so depressed, he was an IIT and he stopped going to college. And now, I could see the positivity. And very recently, he got selected in one of our, major institute in US, and he has moved there. So I just don't like to, chase them away. To be very frankly speaking, I really want to be with them. And somehow from my inner heart, I really want to help them. And that is what I feel. With multiple discussions, I really need try to give them maximum time possible. I feel sad for this patient, to be very frank.
No, I think there's a very specific personality of patients who come to your practice. So it's very difficult to go and please all of them, I think. So we shall go on to our next speaker, Dr. Preethi Oday, and who's going to be talking on my ideal surgical candidate. And she's a very leading oculoplasty surgeon from Chennai, very smart young lady with a huge potential and versatility behind that pretty face. And let's go on to hearing from her.
Thank you, ma'am. Good evening to all of you. And thank you, Dr. Chitra and ARC for this wonderful webinar and this opportunity. Now, I'm sure most of the patients would prefer my previous speakers who give Botox and fillers, because the moment you talk about surgery, you're not very popular with the patients. But we do know that there are certain scenarios where surgery does play an important role in these aesthetic patients. And that is what I will be telling you all today. What is my ideal surgical patient? So whenever we talk about success in surgery in periocular area, we know that it is a lot technique dependent, and it requires a lot of precision in this area compared to other parts of the face. Now, my ideal surgical patient would be a motivated patient with a very strong self-image, who is bothered by a particular physical characteristic that he or she would like to improve or change. So every word in this sentence is important. He has to be self-motivated. Usually I prefer that the patient comes to me with a complaint and I don't find that out for them. And they should identify what exactly bothers them. We can also help them to come out with the right answers during our consultation, and then make a decision together. Usually these patients are in the age range of 30 to 70 years. Now, whenever you see the upper eyelid, when you have gross upper eyelid hooding, now this is an extreme patient that I have chosen, but I just want to tell you that if it is a gross upper eyelid hooding where you have a functional visual field problems, then surgery is the only option for these patients, because you may need tons of fillers for this kind of a face for you to, even improve the volume. And this kind of sagginess definitely needs surgery. So when you want to do volumetric changes in the fat prolapse that you see on the medial side, you have a superior sulcus defect, you have a lot of hooding, you have a broad droop. All these together you can do by surgery, and which does not need repetition also like fillers, and also you will need large volume of fillers, which is quite expensive. Now, when Adit was talking about 14 syringes of fillers, you must remember that each syringe is around 25,000, and you can imagine the bill that can go to the patient. But when you have these kind of patients who are actresses, whose look their profession demands the good look, and they are in their yesteryears and they are scared of surgery. So these kind of patients, you can give them a rejuvenation with Botox and fillers. And that is what I have done for this particular patient. But when you want to correct in a middle-aged lady like this, the hooding, the lower lid hollow, as well as some amount of fat prolapse, volumetric changes, I would choose surgery for this patient. Also, when you have Asian eyelid where you want to create a lid crease, it is a surgical indication. Or when you have a lash ptosis causing ocular irritation because of an excess of upper eyelid skin, you're going to choose blepharoplasty, and no amount of injectables will help you with that. Also, when you have ptosis associated with dermatochalasis, you have to have surgery, and also for lacrimal gland prolapse, like in this patient, if you evaluate the upper eyelid, you can see that she has bilateral lacrimal gland prolapse, she has hooding, she also has quite a lot of fat prolapse in the lower eyelid, and I would take this patient up for surgery and not venture into Botox and fillers. Now, when you have a lacrimal gland prolapse like this, you need to reposition the gland, and that is what is the technique here, and you cannot camouflage this very well with fillers, because in different positions of gaze, it will be appearing separate from the filler. Now, when you have a young patient like this who wants symmetry in the upper tarsal show, like she does not have a tarsal show on the right side, but has it on the left side, you want to symmetrize it, you're going to do a skin alone excision on the right side to symmetrize, and again, surgery is indicated. When you have a bulky eyelid like this, where the brow fat pad is prominent, and you also want to change the volume in the upper eyelid, I would use a brassiere suture along with excision, some amount of excision of orbicularis along with the skin to correct this kind of an eyelid. So this is the brassiere suture that I'm showing you, which is from the orbic to the periosteum, again through the orbic, which keeps the brow fat pad in position. And when I excise the orbic in these kind of patients, I prefer to do the superior orbic excision alone, so that you correct the volume to some extent, but also the function of the eyelid does not change significantly for these kind of patients. So this is what I do. I remove just the skin first, and then I remove just this upper part of the orbicularis that I'm showing here, and entire lateral part of the orbicularis, so that the patient also has some amount of brow elevation on the lateral side, which is desirable. Now, this is another patient who has a deflation of brow fat as well as excess of eyelid skin, and I would choose this patient for surgery. Now, as Adit also mentioned, that when you have a mild grade of tear trough like this, you would prefer a filler, and that's what we have done for this patient. But another patient here who also has a grade 2 kind of a fat prolapse, you can camouflage it with filler, but she also has a lower lid retraction and scleral show, which is more prominent, and that needs correction. And so this is the result that you would expect with a filler. But I would say that surgery would give a better result for this kind of patient. Now, another patient who has gross fat prolapse, again, I would do a fat repositioning for her. And in this patient, we have no doubt that he needs surgery. And I would do a minimum excision along with a fat repositioning for the lower eyelid, and also tighten the lower eyelid in that patient. Now, when we choose a surgical candidate, you should remember that the patient should not be on blood thinning agents. Now, the mistake that we do is many a times patients are using over-the-counter blood thinning agents like ginseng and omega-3 fish oil capsules or some vitamins, and this history is important before surgery. Also, generalized skin conditions, many of these patients feel that history is not important because they are undergoing face surgery. but they can be on steroid long term, and that affects the quality of the skin. The fragility of the vessels is high. Post-op period is more tumultuous in these patients, and we must remember to ask this history to the patients. Another important history that I find is sinusitis, cold and cough. Like if they have a lot of allergies, these patients have fluid retention on the face, and you find that this fluid does not go off very easily post-operatively. And again, you have a difficult post-op period. So I like to treat these before the patient undergoes surgery. Also, all my blepharoplasty patients, I do a dry eye workup, because we find that after blepharoplasty, their grittiness, foreign body sensation, the dry eye symptoms become worse, and therefore it's a good idea to do the evaluation and treat the dry eyes before the procedure. Also, history of glaucoma medications is important, because many a times we put these patients on steroids post-op, and that can be
8 o'clock
to the patients who are already having glaucoma. Also, if they have a bleb, you would not prefer a posterior approach for their ptosis correction. And also the lid margin evaluation is important, because they will again have ocular irritation, which will be aggravated in the post-op period. Of course, the patient shouldn't have had an intraocular or refractive surgery at least for a couple of months before the aesthetic procedure. And one important history that I find in most of my cosmetic patients, especially if they are actors who are in the media, very often they use ocular decongestants, especially during shooting. And you may miss underlying thyroid or superior limbic keratoconjunctivitis or allergies. And you must see these patients after discontinuing the decongestants for some time in order to unmask these ocular conditions. Also, when you advise surgery to the patient, we must discuss with them the downtime, because it's not magic. It's not going to look totally normal in a week's time. And generally, I ask them not to have a social event at least for a couple of months after surgery. You can see this is the timeline that you see. A 1 week post-op patient usually has so much of ecchymosis and edema, which usually settles after 6 weeks. Also, you must discuss what kind of technique you're doing with these patients, because if you have a lot of lateral hooding, your scar will extend a little laterally, and which will be visible like this. And patients should be able to accept that in the post-op period. Now, these are the various timelines that you can see with many of the patients, like 1 week post-op, 2 weeks post-op, and 6 weeks to 8 weeks post-op. So that is the timeline that we require when we plan a surgery in these kind of patients. Also, in Asian blepharoplasties, we are doing a very tight lid crease. In that case, sometimes you will have asymmetry in the lid height for the initial post-op period, which takes a long time, about 3 to 6 months to settle. And therefore, Asian blepharoplasty patients, I often tell them that we will require that kind of timeline. You can see here the edema in the pretarsal area lasts longer time in these patients compared to our non-Asian patients. Of course, we have all talked about red flags in our aesthetic practice. It has already been discussed by my previous speakers. Even for surgery, I think we should know when not to operate. And a patient in crisis who has lost a dear one or who has had a divorce recently, you must not take up these patients because they have unrealistic goals. The surgery is not going to change their situation, and we must wait till they overcome that crisis. Also, if patients like this want to become like this, it is not realistic. Even Milind can't transform me to that. And we must have realistic expectations. If the patient is asking for a particular celebrity nose, it cannot be done. If they want to look absolutely normal after a very severe facial trauma, that's not realistic. Or if they want to look a couple of decades younger, that is also not realistic. So you must understand what the goals are for the patient. Also, some patients are impossible to treat. They go from doctor
1 minute remaining, ma'am.
They want the answer to their question. And those are the patients you must avoid. And also patients who are obsessed with a very minor defect, because sometimes a very perfectionist patient can be a good patient for you as long as they understand that the surgical results may not be exactly what their goal is. Thank you for your patient hearing, and thanks for this wonderful opportunity.
Preethi, that was a wonderful talk and a very detailed talk. So do you think that when you do surgery, it can be combined with these fillers and all that, or surgery itself gets the end result?
So many a times we have hollows post-operatively where you can do touch-ups later, but I like to wait for at least a couple of months after surgery and then do all the touch-ups with the fillers. And I always tell the patients that after blepharoplasties, usually post-inflammatory hyperpigmentation will be there. They will have a little bit dark circles. And if you wait for 2 or 3 months and then decide on the filler injections, it is a little better.
Dr. Shubhra, any question? Because we have 4 more speakers.
Not a question, but just a point here. I think this whole session was about who's the ideal candidate for injectables and surgery. I think there is no ideal candidate in the end. And also, I think you have to look onto the face totality and have a combination therapy. Some patients would require a stage 1 a surgery and may require stage 1 as injectables or vice versa. So I think a combination therapy is what works the best in totality. And I think all the speakers have covered the points beautifully and shown beautiful results at their ends.
Thank you. Thank you very much. So we shall now go on to Dr. Milind, who's going to be talking on my most difficult case.
Is my slide visible?
Yes, yes.
Well, at the outset, I'd like to thank AIOS ARC, particularly Dr. Chitra, for putting together this wonderful ocular aesthetics session. My presentation is not going to be 15 minutes, and I'm going to make a combination of slides and a quick video. So Adit, I'm sure, would have guessed already which case I was going to discuss. So here's a young lady, and she had this frontotemporal cystic lesion, and it was very obvious that it was a dermoid. The challenge was that in 4 months' time, she was going to get married. And the challenge she put across to us was to get rid of this without a scar. And this presentation is entirely on this topic. I purposely chose this case because this has been one of the most challenging cases. And this also hovers between functional and cosmetic stuff. So I'm sure most of us as surgeons can relate to these. A quick brief about dermoids, and these are some of the examples of dermoids that were excised in not very ideal manner. Although the lesion went away, but the scar remains. And this is a child who's going to grow up and always mention your name, that so-and-so doctor operated on me. Not a good idea. A better idea in these cases is to take a lid crease incision so that at least it'll be hidden in primary gaze, although in down gaze you can still see a scar, and the scar obviously would fade over time. There are certain lesions which are fixed to the bone, not very easily amenable to be dragged out through a lid crease incision. And in those cases, we may have to choose a subbrow incision. But in these cases, rather than taking a large incision and excising the entire lesion, what I prefer is to make a small stab incision, expose the cyst, puncture it, aspirate the contents, and then remove the wall. For lesions which are beyond the temporal nuchal line and lesions which are in the frontotemporal region particularly, one of the options is to take a pretracheal incision, which is just within the hairline, and you can excise the lesion, but obviously you're going to have a scar there. And although that heals well, that is still something that a patient might refuse. We have reported a very small series of patients where these lesions were in obvious areas, and we have removed them by just making a puncture, aspiration, and sclerotherapy. With our patient, although we did not have a scope for sclerotherapy, although that was an option, an incision above the brow was not possible. So I'm just going to shift to the video now. Let me just go to the file. Right. Is the video visible?
Yes, yes.
Okay, so in this patient, we chose to remove this endoscopically. And what we did here is to take plan incisions within the scalp and go with an endoscope and excise the lesion without an external marking. So this is something which we would do for endoscopic brow lift, but here we applied this philosophy for the removal of this particular cyst. So just to quickly revise the layers of the scalp, this was a very nice clay model made by Varshita, one of our fellows who's with Narayan Netralaya right now. That's skin. And then you have below that is your connective tissue layer. Then the frontalis, which is within the epicranial aponeurosis. Then you have a loose areolar tissue. And finally, the yellow thing that you see down below is the epicranium or the pericranium, below which you have the bone. So we plan to expose this cyst through stab incisions in the scalp and then go ahead and remove it. So these were the two incisions that were planned within the scalp area, and we mapped out the locations. One was for the endoscope and the other was to pass your surgical dissection instrument, which was a scissors in this case. So you have an inset where we are showing it on the model. We took an incision all the way right up to the pericranium, dissected just above the skull bone, also into the temporal fossa. So once you create that space, then you have an opportunity to pass the endoscope into that space. And the endoscope for brow always goes along with a sleeve, and you can see the sleeve being advanced onto this model here, and soon we'll shift to the actual surgical video. So that's your endoscope sleeve. You can see the metal hook on the top, and that's at 12 o'clock, and we are already into the space. And down below you see the yellow lesion, that is your dermoid. So if you look at the inset, you have the endoscope on the right side and the scissors in my left hand because I'm left-handed. So that's the cyst, the scissors, and the endosleeve. And we did this in two planes. One is between the skin and the dermoid. That's what is being dissected now. So in the inset, you can see that the scissor is above the red lesion. And we could only go up to a certain extent because at a certain point, this was over the hill and we couldn't really see beyond it. But we could get almost 2/3 onto it. Unfortunately, dermoids don't have great vascularity around them. So we've just been separating the tissues on the top surface of the dermoid, and that's what is happening here on either side. And in a particular region, you would see that's the cyst, and you'll obviously reach the vein somewhere at this point, which is also encountered when you do an endoscopic brow. That's the sentinel vein. So we hold it with an endocautery and touch it externally to cauterize that, just to avoid a hematoma. So that was the top surface. Then we went on to the surface below the dermoid, which is lifting it right off the bone. That's the area where there is a possibility of the dermoid rupturing as it's come out through a suture. But we could dissect that through this plane. And eventually that entire intact bag of dermoid was ready to be kind of squeezed out through the small stab incision that we had made in the scalp. So that's the frontal bone you can see at the base. So we've almost dissected the cyst off the bone. That is when you can actually hold it with the forceps and actually pull it out. That's what is being done here. And as you can see, obviously through an endoscope, it's difficult to demonstrate its exit, but it was eventually pulled out through the stab incision. Once it is out, you just examine the leftover bed. Make sure that you don't have any active bleeders. You don't have any components of the cyst wall left, which was obvious, and we had the wounds stapled. So wound care for 2 weeks, and we had a patient who was 1 week follow-up and then finally a couple of weeks post-surgery without an external scar, and the cyst was gone. So in my opinion, this was a challenging case which was bridging between cosmetic and functional both. Thank you.
Amazing surgery. I'm spellbound actually. That was truly nice. I enjoyed watching it. Supposing if some of these lesions have an intracranial extension, you couldn't have done this, no?
No. In those cases, obviously, if the decision is surgical, then we would involve a neurosurgeon. Most likely that surgery is not going to happen in an eye hospital.
But again, if it is in the subbrow region, you need not go like this, no? Because it would get hidden by the crease, no?
Yes, absolutely. Yeah, I mean, pretracheal was an equally good option here had we chosen that.
Wonderful. Dr. Shubhra?
Yeah, I think Preethi has a question to ask. Yeah, Preethi.
Yeah, Milind, sometimes this incision site area, do the patients complain of altered sensation? Some of my patients had that, and what could be the cause? Or do you see it in your patients?
Well,
as they say something like tingling and altered sensation.
The initial period, yes, but I haven't had patients. If your stab is well back enough in the scalp and if it's radial, I think unless you have unfortunately hit or cut a nerve, it's unlikely. It's less likely.
Because it was bilaterally felt, so I didn't think that the incision could be the issue.
If not the incision, then the stretching during your endoscopic brow lift when you are close to the supraorbital rim. It depends on the indication, but if I'm damaging the nerve closer to its origin, I wouldn't know that if I've done just stretching, and then that I would suspect that as the reason.
Yeah, I think that makes sense. Yeah.
Thanks a lot, Dr. Milind. We could have asked you a lot more, but I think we have to go on to the other speakers. But you gave us, at least to us ophthalmologists outside oculoplasty, something to remember. So we go on to our next speaker, Dr. Debraj Shome, who is a very leading facial plastic oculoplastic surgeon of the world based in Mumbai. And his video would be played, but I do wish he's connected. Very unfortunate that he's been unwell. I do wish he's able to answer any question which comes along. So shall we run the video, Dr. Anand?
Yes, good day, everyone. Thank you for having me here. My name is Debraj Shome, and I shall be speaking on my most difficult case in this particular presentation. Certain financial disclosures are a must. I am a faculty and a trainer for Allergan, MERS, and Aptos for the past decade. And obviously, the aesthetic clinics, which is now in multiple cities all over India, we would never be as good as we are with some of our results if it wasn't for our dermatology team, which does a wonderful job in making our surgical results look better. Please do not record this presentation, and please do not disseminate this presentation or the patient photographs in any way without our written approvals. In general, facial plastic surgery is a fast expanding super specialty of plastic surgery. And we understand that facial plastic surgery or aesthetic surgery can be divided into reconstructive, cosmetic facial plastic surgery, and the non-surgical rejuvenation procedures. Now, today's case is going to be talking about reconstructive facial plastic surgery, and mainly due to trauma.
We are not getting the,
Nasal tip refinement is amongst the most complex tasks, especially in a broken and traumatized nose. A broken and traumatized nose is pathological from the sense that it has a lot of scar tissue, and that is why nasal tip refinement, rhinoplasty, becomes even tougher. This video attempts to demonstrate the surgical technique as well as the thought process behind nasal tip refinement techniques used in a broken and a traumatized nose. Our patient is a 32-year-old Iraqi lady who was a bomb blast victim. The bomb blast led to the loss of her right eye and led to a huge nasal abnormality, leading to deviation of the nasal septum as well as a huge bulbous nasal tip due to the formation of a large amount of scar tissue post the injury. This video is not only about surgical skills, but it is also about human suffering. How do we, as plastic surgeons, get such a young lady to lead an essentially normal life is the real story behind this video. This is a close-up of the patient's face showing the nasal as well as the facial abnormalities which have developed post the injury 1 year ago. The patient needed a right eye reconstruction with prosthesis fitting into the socket which remained. Since the facial bones had fractured post the blast injury and these had not been united properly by craniomaxillofacial surgery, this needed a face transplant-like surgery where we had to break all the malunited facial bones and reunite them. This was akin to breaking all the facial bones which had malunited and refitting them almost like a jigsaw puzzle. This was an interesting surgery which was subsequently covered by Reuters as well as top newspapers globally. The focus of this particular video though is the rhinoplasty surgery, especially the tip refinement which was carried out in this particular patient. The plan for the nasal surgery in this patient was to lower the nasal dorsal hump, recenter the nose and straighten the nasal septum, create a vertical dome division which is a hockey stick reduction of the lower nasal cartilage, and to straighten the columella and to make the nasal tip triangular from a bulbous tip. The lady had thick sebaceous skin. In addition to this, she had developed a large amount of scar tissue which also needed to be reduced over the nasal tip to give it a more refined, triangular looking nose. The hockey stick method involves vertical dome division and modest excision of the lateral and the medial crural elements to refine the nasal tip, thereby shifting the nasal tip from a boxy one to a triangular pyramidal one as is shown in this photograph. The key word is modest excision, which means a severe excision will lead to long-term changes in the nose and failure of support elements of the tip in the longer term. This is a photograph which demonstrates the changes which can be brought about by the hockey stick technique of vertical dome division. While the hockey stick technique has been reported earlier for tip refinement, to the best of our knowledge, it has never been reported before in a traumatized nose. A transcolumellar broken line incision was used to gain access to the nasal tip. The scar tissue on top of the nasal cartilage and underneath the skin envelope was slowly trimmed down. Vertical dome division was performed. The callus on top of the nasal dorsum was slowly
Why has the volume gone?
Those are the osteotomies being performed, and the osteotomies are performed to medialize the nasal bone and to make the nasal bone come closer, thereby giving rise to a much more refined nasal appearance. These are the transdermal sutures being taken, and the medial crus of the lower lateral cartilages are being sutured together using, in this case, 6-O-proline sutures. That's the nasal tip complex which has now been created, and you can see how the nose already looks a lot more
The transcolumellar incision is now sutured with 6-O proline sutures. The nasal tip is now taped with steri-strips to support it, and then a thermoplast plaster is put in place to support the entire nose. This is the final picture of the patient taken 6 weeks post-operatively. This is how the patient had presented to us, and this is how the patient now looks 6 weeks post-surgery. Quite a remarkable difference, isn't it? This case, both from the human interest angle as well as the surgical achievement, was reported in a number of top-line newspapers globally as well as by Reuters. In summary, meticulous nasal tip refinement techniques performed in broken and traumatized noses can give wonderful post-operative results. Hockey stick technique
So in essence, we have demonstrated a craniomaxillofacial surgery. You have seen only one part of the surgery, which is the nasal refinement. But in general, this patient underwent a transcoronal flap, and we've gone ahead and taken the entire face down and repaired all the bony fractures of the face, literally in a jigsaw puzzle-like manner. This was an 11-hour surgery. And after multiple surgeries and post the prosthesis fitting, this is how you can see you can see the patient, how the patient looks immediately post the surgery, approximately 6 weeks later. So these are the sort of changes which can be brought about. And in that sense, every fracture, every surgery on the face is actually an aesthetic surgery, because we get a chance to really impact the patient's life completely. That's the patient with a much younger looking me about a decade ago. And the patient has been on follow-up since then and is doing really, really well, even now with the prosthesis and all the fractures which have done. And the scars have healed beautifully well. Obviously, the scar is behind the hairline, so nothing much can be seen on the face in that sense. Now, this brings us to an important point. Whenever we are training fellows, we are actually training them in orbital surgeries, especially in oculofacial plastic surgery in India. However, we wanted to also discuss what are the sort of fractures which are typically seen at a tertiary care trauma center. So the WHO statistics are that Indians are driving faster than ever before, and the Ministry of Road and Traffic in India tends to suggest that there are about 15 million Indians who die on a yearly basis just from road traffic accidents. The face is obviously the most exposed part, and it's commonly injured during the road traffic accident. And that's why maxillofacial trauma becomes very important, to do it properly and to give the patients a better life. Now, some fractures will remain restricted to the orbit, but in general, craniomaxillofacial injuries will involve the other orbital wall as well as the rest of the face as well. Therefore, we need to train our surgeons, whichever discipline they come from, in treating fractures of the entire face holistically. Now, this was a retrospective study, and this was conducted on the number of facial plastic surgery performed in facial fractures, which had come to the aesthetic clinics from 2006 to 2019. And that's some of the data, with a 2-year follow-up being followed. And after the patient has been stabilized, obviously the airway, the circulation, and making sure that the person is breathing properly are the most important. After that, the CT scans are examined, and then we perform a complete evaluation. Generally, many of our traumas which involve the frontal bone as well are operated with the neurosurgical intervention as well. And these are some of the treatments which had to be done. Now, if we look at the 1,508 patients who were included, we can see that there is a positive correlation of the age with the degree and the nature of trauma. We can see that males, as has been seen in other parts of the world, are significantly more prone to road traffic accidents. And the commonest cause of facial injury was actually road traffic accidents, followed by assaults and sports injuries. And that's the entire breakup over the 13-year period of this retrospective trial. These are the types of fractures. And you can see that while obviously the aesthetic clinics were started by the oculofacial plastic surgery genre, but now we have multiple surgeons, and you can see that the orbital fractures, even though they formed a majority of the number of fractures which we were seeing, which can be it can be a confounding variable given from where our practice started, but you can see that the panfacial fractures and the complex facial fractures account for significant number of trauma. So as much as 68% of the number of patients who presented with trauma did not have only isolated orbital fractures. And these were the treatments which were done, with open reduction and internal fixation being the typical way of treating the fractures, but there were other procedures required as well. And these are, of course, some of our patients with a frontal fracture, with maxillofacial trauma, zygomaticomaxillary fractures, comminution of the maxilla itself. And these are how the patients look after multiple procedures have been performed. In general, the fractures are common in the young males, peak incidence being between the 2nd and the 3rd decades of life. And most importantly, only 30% of the trauma or of the fractures in our trial were isolated to the orbit. A multidisciplinary approach becomes better, and we need to make sure that the future surgeons who are being trained in whichever discipline or whichever residency they come from are being trained to treat facial fractures holistically all over the face. This study is also been accepted in the Craniomaxillofacial Trauma and Reconstruction, or the CMTR journal. And this is, of course, how carbon dioxide laser resurfacing also is performed. And ancillary skin treatments like these can make our fractures look much better post-treatment. These are some of the trials which have come out of the aesthetic clinics over the past 3 to 5 years. And you can see varied topics, including facial fractures, etc., as a result of which we believe that any cut on the face is actually an aesthetic surgery. It doesn't matter whether it's a fracture or a tumor as well. These are some of our training programs we love to teach. And if you would love to learn, please contact us when we are happy to train you. And that's a book which has now a bestseller on Amazon. It has been written by 30 of the topmost doctors and surgeons from across the globe. And it talks about, the great things that we as doctors do. And it's something that we recommend reading by all of you to feel more energetic and to also feel proud of what our fraternity as doctors is achieving, especially at these COVID times. Thank you for your kind attention and a patient hearing. And that's my email address. And if there's anything that we can address, please don't hesitate to reach out. Thank you very much.
Thank you, Dr. Devraj. That was a wonderful talk. It is just that when you're dealing with some very high profile patients, I'm sure there are certain predictable parts and unpredictable parts. It must be a challenge for you to counsel these patients, and the results may be not exactly idyllic in all times, no? Are you there?
Yes, ma'am, I'm there. Good evening, everyone.
Yeah.
Yes, ma'am. Obviously, one question that we get asked all the time is a fracture case which has multiple fractures on the face, is that more challenging as a surgeon, or is performing a 1 millimeter lift of the tip of the nose using fillers more challenging? I think the challenges are different in both these particular conditions. In one, which is the surgically challenging cases, the people are willing to accept even slightly subnormal results, whereas the people who are coming in who are actually normal looking patients and want to look super normal, their expectations can be very high. So therefore, patient management, good communication, and great consents are very, very necessary in order to make sure that we take care of our patients really well. And in that, managing the mental state of the patient is also as important as managing the physical state, ma'am.
Thank you very much, Devraj. Thanks a lot for those words. I know it must have been difficult for you to stay connected, but paucity of time, I have to move on. So we go on to our next speaker, Dr. Deepa, who is a very leading dermatologist and a cosmetologist from Coimbatore. And we would look forward to her inputs in this ocular aesthetic session. Dr. Deepa, could you unmute yourself and get connected?
Yes, ma'am.
Yeah.
Yes, ma'am. Good evening. Good evening. I'm going to give you all a brief presentation about facial rejuvenation, a dermatologist's perspective. Facial rejuvenation is composed of a large group of cosmetic procedures, both surgical and non-surgical, designed to make facial skin and appearances look younger and refreshed. Facial rejuvenation is much needed nowadays because there are many.
Ma'am, your slides are not moving. Have you changed the slide? You're on which slide right now, ma'am?
She's on a second slide.
Second slide, ma'am.
Yeah, maybe you should keep clicking on each slide as you go down, or you go to slideshow.
She's on slideshow, but it's not showing.
Oh.
Same problem.
So you will have to click on each slide.
Yeah,
yes.
Now it's coming.
Oh, yeah.
Now it's come.
No, it hasn't gone to slideshow.
No, this is fine, ma'am. We can do it this way only, Dr.
Yeah, we can do this way, yes.
Shall I continue, ma'am?
Yes, yes.
Okay. Facial rejuvenation is composed of a large group of cosmetic procedures, both surgical and non-surgical, designed to make facial skin and appearances young and refreshed. Facial rejuvenation is much needed nowadays because there are many who try to recapture their youthful appearances, fighting the age game, and keep looking and feeling their very best as long as possible. There are social and psychological choices such as advertisement from print media, TV shows, and celebrity endorsement for beauty products, and peer pressure, which influences people to look for facial rejuvenation treatment. There is a lot of demands for non-surgical procedures nowadays because it is minimally invasive with no downtime. It can be done even before an hour prior to any important occasions. Recovery is also very quick and cost effective. Dermatological procedures that we do for facial rejuvenation is of two types. One is non-surgical and another is minimally invasive procedure. Non-surgical procedures are skincare regimens, chemical peels, microdermabrasion, and lasers. Minimally invasive procedures are microneedling, platelet-rich plasma treatment, Botox, fillers, and thread lift. Basic steps in any facial rejuvenation procedure is the selection of the good skincare regimen. This is useful in early signs of aging and to maintain the skin after rejuvenation procedures. We use products such as alpha hydroxy acids, retinoids, vitamin C, sunscreen, and peptides. Chemical peels are done by applying chemicals which causes inflammation, exfoliation, and destroys skin cells in a controlled manner. Indications are sun damage, wrinkles, acne, melasma, and scarring. Chemical peels are classified into superficial, medium, and deep peels depending upon the depth of the peels. Superficial peels are glycolic acid, salicylic acid, and gessner solution, 10% trichloroacetic acid. Medium peels are strong gessner solution, bisocinol, 15 to 20% trichloroacetic acid, low concentration phenol. Deep peels are phenol, 30% trichloroacetic acid. These are the before and after pictures of the patient who took chemical peel treatments for acne and melasma. There are visible results after 4 sittings. Microdermabrasion is a method of skin resurfacing involving mechanical exfoliation of upper layer of epidermis. It causes stimulation of epidermal cell turnover along with vasodilation, dermal edema, and collagen remodeling. To abrade the skin, we use aluminum oxide crystals and diamond tip. Laser treatments is of two types, non-ablative and ablative. In non-ablative laser, light energy is focused on the deeper skin. Among the non-ablative lasers, we use Q-switch Nd:YAG for pigmentation and nevus and erbium glass Nd:YAG for scars. The patient in the first picture is treated for pigmentation with Q-switch Nd:YAG laser. The patient in the second picture is treated for nevus of aorta with Q-switch Nd:YAG laser. Ablative laser damages skin surface layer. We use fractional CO2 laser and erbium YAG for scars and resurfacing. These are the before and after pictures of the patient who took laser treatment. We can see visible changes in the scars and skin texture. Microneedling is microneedling, the results are obtained by percutaneous collagen induction by mechanical trauma. We use derma roller and derma pen for microneedling. Compared to derma roller, derma pen has control over the depth of the needle. These are the pictures of the patient who has undergone microneedling. The results are convincing after 4 to 5 sittings of microneedling. PRP treatment is an autologous high concentration of platelets in a small volume of plasma. On activation, these platelets release various growth factors that helps in regeneration and restoration of human tissue. Indications of PRP are rejuvenation and scars. It is also called vampire facial. These are the pictures of the patient who has undergone PRP treatment. The results are visible after 5 sittings. As our speakers have already enriched us with all necessary information about Botox and fillers, I would like to move on to the next treatment, thread lift. Thread lift. The entire basis of thread lift technique is the cutaneous response to the presence of polydioxone thread within the skin. It is similar to the typical foreign body response of the skin. Types of PDO threads are monothread, twin threads, and cock hook threads. Indications are wrinkle, facelifts, stretch marks, cellulite, volume reduction, skin brightening, pore tightening, acne scars, facial asymmetry. The results are immediate and long-lasting. I would like to conclude my presentation by stating that facial rejuvenation is an existing field of art and science with an ever-expanding indications and procedure. Thank you.
Thank you very much, Dr. Deepa, for your inputs. But it's really running behind time, and we shall move on to our last speaker and the star speaker, Dr. Kasturi Bhattacharya, who's going to be talking on problems and solutions in ocular aesthetics and expert guide. On to you, Dr. Kasturi.
Yeah. Can you see my slide?
Yes, yes.
Yeah. At the outset, I would like to thank you, Dr. Chitra, AIOS and ARC, for giving me an opportunity. So I'll be speaking on the problems and the solution in ocular aesthetics. Let me start by mentioning that any problem that comes to us, we always question what is the problem, when it occurred, how it occurred. But the answer is one, that we need a solution, we need to revise it. And the second question is that what is the aim of the aesthetic procedure? Is it for symmetry or is it for beautification? For many, the beautification is a combination for symmetry and contour, which I do not agree. For me, beautification is basically alignment and harmony. So I start my talk by quoting Atul Gawande, who has mentioned that no matter what measures are taken, doctors will sometimes falter. Whether you're a very expert surgeon or whether you're just a novice surgeon, you can falter. And it isn't reasonable to ask that we achieve perfection. What is reasonable is to ask that we never cease to aim for it. So in aesthetic practice, whatever is the problem, we need to have the solution, and all solutions should aim for perfection. So as a facial aesthetic surgeon, it has been discussed so well, like we do multiple aesthetic procedure, which can be in the form of injection botulinum toxin type A, which can be for different indication, like for the crow's feet, for the eyebrow, or for the dermal filler, which can be used for a mid-face lift or your lip augmentation, or a chin augmentation, or the slimming of the face. So there are multiple indications and the multiple use for dermal fillers, and every situation you might have a problem, but you should know how to have the solution. And Dr. Deepa has already shown, nowadays most of us use extensively the facial thread, and like I really love using it. This is a cork thread that you can see, which is basically used for the facelift, and also you can use the other type of face, especially the twin thread or the mono thread, which are also used extensively. So you can have a problem during this stage or in any of the stage of doing any surgical procedure, like an upper lip blepharoplasty, where you can see when you need to cut the different layers of the upper lip, or even a small procedure like a medial epicantoplasty, where you need to manage the medial epicanthal tendon along with excision or a subcutaneous tissue, or a lower lid blepharoplasty, where you form the beautiful fat pedicles. And what you need to transpose this fat, which acts as a homologous tissue, which acts as an autofiller and fills this tear trough, and down also it leads to good effacement of the lid cheek junction. So all these are the multiple procedures which is done by any of the ophthalmologists doing a facial plastic surgery. But what are the main complications that can occur in the form of the bruit, hematoma, asymmetry, infection, vascular complications, and many a times over and under correction. So the injection site complications are usually transient, reversible. They usually come in the form of erythema, local edema, bruising, and the solution to it is avoid aspirin, avoid NSAID, avoid the green teas, avoid vitamin E and the other anticoagulant a week prior to the surgery. Use a small gauge needle, and icing, which has already been discussed today, can minimize the pain and also cause a vasoconstriction. Many times, however great you are, you can have complication like in the form of ptosis. You can have also in the form of either a brow ptosis, or you can have in the form of the lid ptosis. But another common complication which can occur in anyone's hand is the asymmetry, where you need to do a symmetrization by giving another unit of Botox, and thus you can help and treat the solution. Then other complication has already been mentioned by my previous speakers very well. So we should always understand the patient's psyche, make them a part of the decision making, evaluate the entire face for a holistic appearance, and address the man-made, inadvertent, unintended error. And even if you have a minor asymmetry and imperfection, you should try for harmony. As already mentioned by Aparna, like we all know that this minor imperfections are very common in dermal fillers because it is classified as device and non-medication. Like medication, we have like one tablet TDS, but for fillers, we do not have any volume, we do not have any unit. So sometimes the main complication that can occur is volume too much or too less. The depth can be too superficial or too deep, or there can be also some unfavorable anatomic site injection. And for ophthalmologists, the most common indication for us is the management for the tear trough deformity, which we usually do with a needle. And when we give with a needle injection, we get beautiful results. And this is what most of us practice initially. And you can see here, like this is a girl where I'm trying to manage the tear trough. I'm injecting on one side. And moment I complete the one side, you'll see this is the site yet to be injected. And what you see, the tear trough is being nicely taken care of. You'll see that a good concealing of this eye bag. And this is the side injected, and then you go to the other side. So this is what we do in most of our practice. Initially, all of us have started with the needle injection, and the local site injuries are very common. The complications are very common with the tear. Like you can see, one can be in the form of a lumps and bumps, as you can see here, and there's a solution to it, like the hyaluronidase. And there can be other complication, like this is the case of bolite, where you give for the skin, and you can see the small bumps, as you can see here. And also it can form other complication in the form of the Tyndall effect, which is better seen in the daylight, or it can be in the form of an inflammation, or it can be form of a bruise. So what is the solution to this? How we avoid this bruise or lumps and bumps? The best way is by using a cannula, which I usually believe is a very nice way of managing the tear trough because it leads to a very nice tissue integration. Hardly you'll see any bruise, hardly you'll see any lumps and bumps. And it really gives a very good effacement of the lid cheek junction, manages the tear trough very well. And this is how you see, this is the lady where you can see a little amount of tear trough with the eyelid bag, lower lid bag, and this is approximately 2 days following the injection. And this you can see with this dermal filler, you can really conceal the fat. Adit has shown nice pictures, even the previous speakers, Shubhra, Milian, all have, we are discussing about it. This fillers really conceals the fat and also corrects the tear trough deformity. And also the most important, it makes a rejuvenation of the face and it converts a negative vector to a positive vector, along with the correction of the tear trough and also the eyelid bags, which can be done both surgically. And the results are instantaneous. You see, this is the point of entry of the cannula, and you can see this immediate following the treatment. You can see so beautiful correction, but you can also have lots of complications, especially in the form of the vascular complication, where the result can be either the local form where you can have a blanching like this following injury to the blood vessel, or also you can have a remote or a distant effect. However, in the face, we are very lucky. We have the angiosomes, and this has both the choke anastomosis and the true anastomosis. The advantage of having all this angiosome is that in most of these angiosomes, we have the choke and the blood vessels. So whenever these blood vessels are touched by the filiary ambigospasm, so this leads to a local effect in the form of necrosis. But in case it enters a true anastomosis, it might lead to unrestricted flow through the same side or to the opposite side till the point of retrograde flow, and this leads to blindness. So what is the solution? The filler cascade, where you need to have the hyaluronidase, you need to have the steroid, you need to have the nitroglycerin gel in case there is a CRAO. You need to have a paracentesis set, all the antibiotics, and also the hyperbaric oxygen. And when there is a vascular complication, you need to flood the area of the vial, because along with the occlusion of blood vessel, there is so much of release of anti-hyaluronidase substance. So you really need to give in excess in order to overcome the vascular complication. And hyaluronidase itself has got so many complications, like this lady, as you can see, definitely in the COVID era, she came with an inflammatory nodule that you can see here. And this is when I managed this inflammatory nodule with the hyaluronidase, and you can see a delayed type of hypersensitive reaction, which occurred after 48 hours. And then again managed her with the steroids, the hydrocortisone, and she came back to the original shape, but definitely with the steroid phases. Surgical complication can be very early complication in the form of swelling, in the form of hematoma, but these are all manageable. And the most common indication for all of us for upper lid blepharoplasty is to treat the have eyelid crease or to have managed the lateral hooding. But sometimes, in spite of being in the best, do the best surgery, you can have asymmetry like this. This lady comes to us, comes to me with the asymmetry after a month. And when I was looking to her, I was liking the left side, but she was liking the right side. So we are deciding that which side to correct. Ultimately, we decided that we'll correct the right side, and this is after the correction of the right side. And ultimately, you can manage it and you can have a symmetrized eyelid crease in both the sides. This is another very interesting young girl. She comes to me for upper lid blef. And this is what you see. You can see a scar. When she looks down, she was very conscious about it. And then I had just injected 5FU with tricot, and the scar got revised. And this is before just the scar. And this is when she looks down, the scar is totally absent. So all this can be managed. And this is another lady who came for the upper lid blepharoplasty. I had done an extended upper lid blepharoplasty because of the lateral hooding. And what you see here, there has been an incomplete correction of the lateral hooding. So I had taken up very early for revision surgery. And this is what you see, that sometimes you need to take them off for revision surgery when you have a very demanding patient like this lady. She happens to be a very prominent part of a lady from Mizoram. And this uncorrected, which I had again taken up within a 10 days time. And this is the final look that she gets it after the second procedure. This is a very interesting case. She comes to me for her upper lid blef, and this is what we usually say, that we need to give a monofilament suture to suture the skin, and this is a reaction to proline. And this is something very rare I have seen, and this is a proline reaction. And once the proline has been removed, and she was on local steroid, and this is how she looks after a month following this reaction. Similarly, this is very interesting case. This is a xanthelasma, and again, all the skin being sutured with a proline, and this is again the proline reaction that I have seen, and I have removed the proline, and you can see this swelling. Immediately the proline was removed, and ultimately she was on steroid, and this is the final look following all this complication and solution. Lastly, like we are all very fond of, and when we all started blepharoplasty, we used to excise all the fat bed. But what we have seen, that especially in Indian scenario, if we excise all the fat bed and do not transpose or do not use the fat as a filler, then you can have something like this hyperpigmentation and also more hollowing of the infraorbital rim. So these are the indication where we go for post-blepharoplasty augmentation with injection dermal filler. And this lady, we have to following the blepharoplasty 3 months after the blepharoplasty procedure, you can see a dermal filler has been injected again with a cannula, because I always feel the tissue integration is better, and especially post-surgical, the cannula is much better than the needle. And this is how she looks immediately after the injection of the filler following a post-blepharoplasty augmentation. And you can see the pigmentation is much less, and also the hollowness has much less, and she looks a totally different patient after multiple sittings of filler following the blepharoplasty procedure. So what at the end, I would like to mention that whatever the problem, we should be a part of the solution. We should place ourselves in the same situation, and the patient be a part of the solution, and you should focus on the solution and not on the problem. Thank you very much for your patient hearing.
We always keep for the best for the last, and it was truly a very good talk. I know you had to rush through it, but it was just really wonderful. Dr. Shubhra, would you, yes, I have a question before we conclude. What would be your message to the young ophthalmologists who aspire to come into your specialty?
Regarding the aesthetic practice, right?
Yes.
I feel that every specialty is very important and holds equal importance. And the most important thing, that you should have a passion. You should have a passion that you want to do, because it's very easy to do a reconstruction when a face is already deformed and you do a little correction, the patient is happy. But when you work on a normal face and to beautify the normal face, the most important thing that you should have a very clear understanding of the anatomy. You should know your anatomy well. You should do lots of cadaveric dissection, and you should have lots of training and practices before you take up all this challenging case. So when doing a LASIK, when we do a LASIK procedure, this patient already have vision. So we are working on a normal eye. Exactly when we do a cosmetic procedure, we work on a normal face, and only we are giving a more rejuvenation. So you should be very truthful to the patient. If you feel that at some point you need some more training, you should not touch the patient unless and until you're confident that I can do a good job and I can do an honest job for the patient.
Yes, wonderful. Dr. Shubhra, you have anything to ask?
After Dr. Kasturi's talk, no way. No way. I think it was a wonderful talk, I think. So I think we, Raman, Dr. Kamalpreet, if you have any comments, please share.
Dr. Kasturi's talk is always mesmerizing, and it's added up on with such nice pictorial and other videographies and all. So it was all wonderful and informative sessions. Many more things to learn. Always it is never that we are done with the learning part. And every time I be a part of these type of sessions, I think that I'm still learning. And thank you very much, everybody. I have no more comments to make.
I'll just like to say one thing. As usual, hats off, Kasturi. This is just a very random comment, but I think it's very apt here. Maybe like 10 or 15 years ago, cosmetic surgeries and cosmetic procedures were not really considered very mainstream, or were not really, let's say, not respected very much. So, but now, as our social demands have changed, so like a lot of people identify themselves by their profile pictures or by their, Instagram followers. Most of us meet other people on Zoom meetings. So it really, meetings like this, sessions like this are really the need of the hour. And this is something, cosmetic procedures and cosmetic surgeries is something like most of us will now have to join in, even those who have not been doing it in the past few years. So very, very timely. And thank you, Chitra ma'am.
Yeah.
Thank you so much.
This also brings to that problem which Dr. Chitra ma'am asked in the beginning, that how are we as oculoplastic surgeons are placed in the world of cosmetic surgeries when generally the patients go to dermatologists, plastic surgeons, and cosmetologists. I still don't know how should we, take the fair pie from that cake of cosmetic surgeries and plastic surgeries from our other colleagues.
Yeah, but Shubhra was trying to tell me that the patient just walks into a clinic and they know the difference. So I decided that I will end this session believing that, and when you believe something positively, it actually happens. So, but anyway, I think we are running quite late, and I think I realized even more today that beauty and cosmesis is actually a rave for all generations, and the kind of explosion of information and learning which came in would actually haunt us to hear some more of your meetings and get more knowledge, though I would never subject myself to any of these things. Believe me, I also realize that such phenomenal dedication is there amongst you, all of you, because there's a lot of dedication needed to go and redefine something, and there could be some unpredictable associated with it. But hats off to you, expert panel, for your contributions and amazing set of talks by each of you, the most challenging videos and the different things. I'm not going to take the names, but each talk was one to beat the other. And thanks a lot, Dr. Shubhra, for being the true co-moderator, which I needed for this very interesting webinar. My very special thanks to my ARC team for always being there in the background to support me and in the forefront to support me. My thanks are due to Kripal and the entire AIOS admin staff. My thanks are due to Sai and Manjula from Numerotech. I'm sure your inboxes are filled with these ARC mails, and the thanks goes to them. And our thanks are very much due to Dr. Anand Sethi and his team, and you can see how intensely involved they are. I think they need to be given some kind of honorary qualification for having done so much for ARC webinars in the last 1 year. And most importantly, our thanks are very, very much due to our sponsors, the Entort Pharma, who have been there all through my term, and the kind of amazing support they've given is just phenomenal, which always encouraged us to keep coming back. And thank you so much, dear attendees, for you being there, because that only makes us think of how innovative and how different and how interesting we can ever get. And thank you, one and all. Thank you so much. Thanks a lot.
Thank you so much, ma'am. Thank you.
Bye. Have a good evening.
Bye-bye.
Thank you. Bye-bye. Bye-bye.